ونص بقى. بسم الله الرحمن الرحيم. ألف شكر ليكم لحضوركم النهارده. طبعا احنا بدأنا we started our school 3 days ago. Sunday, Monday, clinical cases and some clinical lectures. And Tuesday we had a very nice nerve conduction and EMG course by Professor Zaim Siddiqui, Alberta University, Canada. It was basics, but we know that it was not basics because we still miss a lot in neurophysiology. So today is the fourth day of the school. We will continue our basic education and basic lectures, and we will add some updates, but Thursday and Friday will be the updates of and advances of neuromuscular disorders. So we are late, so we have to start our session.
Rahman Rahim. First of all, I would like to thank Professor Nagia for this very interesting event that I wish that everyone will enjoy science here. The first lecture will be by Dr. Mahmoud Yusri. Dr. Mahmoud Yusri is an assistant professor in National Research Center. He is working mainly in neurogenetics. He will talk about the diagnosis approach of Duchenne muscle dystrophy.
Good morning, everybody. I would like to thank Professor Nagia for inviting me to this lecture, and I would like to thank Professor Mahazaki. She is my professor and mentor for almost now 17 years. And I would like to present the diagnostic approach of dystrophinopathies, Duchenne and Baker muscle dystrophy genetic diagnosis. Duchenne muscle dystrophy is an X-linked recessive neuromuscular disorder caused by mutation in the dystrophin gene, resulting in absent or insufficient functional protein, which is insufficient functional dystrophin protein, which is a cytoskeleton protein that enables the strength, stability, and functionality of myofibers. The incidence is 1 per 3,500 or 3,500 to 4,000 males live birth. It is the largest gene in the body. In human beings, it spans 2.5 million base pairs in genomic sequence. It corresponds about 0.1% of the whole genome. 99% of the dystrophin gene is made by introns, and the coding sequence is 86 exons. We know that they are the protein producing exons are 79, but we have 7 promoter exons linked to the first exon. It encodes a large protein which contains N-terminal actin binding domain, multiple spectrine repeats, and cysteine rich domain, and the carboxyl terminal domains. So we have 4 domains for this protein. The encoded proteins forms a component of the dystrophin glycoprotein complex, which bridges the inner cytoskeleton and the extracellular matrix. Mutations at this gene locus may cause Duchenne muscle dystrophy, Baker muscle dystrophy, and cardiomyopathy. Alternative promoter and alternative splicing results in numerous distinct transcript variants and protein isoforms of this gene. The Duchenne muscle dystrophy gene is very large, and, decoded by 79 exons, tightly regulated internal promoters, which make a range of protein isoforms, identical at the C terminus, but with unique N termini. Different dystrophin isoforms are localized in a distinct region in the CNS and retina. Absence of the dystrophin from these sites is responsible for the extramuscular manifestations of Duchenne muscle dystrophy, including neurodevelopmental disorders and disturbance in the retina extrophysiology. Mutations downstream to exon 30, which affect dystrophin protein 260 expression, are associated with abnormal scotopic ERG waveform and some impairment of red and green color vision. Dystrophin gene, we can see it's on the short arm of the X chromosome. The vertical lines represent the 79 exons, and and we can see that we have different promoters in the along the dystrophin protein. The brain promoter, muscle promoter, Purkinje fibers, retina, brain 3, and we have the retinal promoter, muscle, Schwann cells, and general promoter. You can see the different isoforms, different in lengths. This is the full length, and this is the isoform dystrophin protein 260, and the others are shorter, represented according to the tissues in which they are transcribed. The domain composition of the various dystrophin proteins is indicated. The amino terminal domain is followed by the spectrine-like domain, cysteine-rich domain, and the carboxyl domain. All of the transcripts are similar in the carboxyl and cysteine-rich domain, but different in the N-terminal domain. The largest isoform of the dystrophin, we have the amino terminal domain. It has homology with the alpha-actinine and contains between 223 and 240 amino acid residues, depending on the isoform. And then we have the central rod domain, which is contains of 25 triple helical repeats, similar to the spectrine, and contains about 3,000 residues. We have the cysteine-rich domain, and then we have the carboxyl domain, which comprises 420 residues. One of the main roles of dystrophin glycoprotein complex is the stabilization of the sarcolemma and protect the muscle fibers from long-term contraction-induced damage and necrosis. The different isoforms of dystrophin protein, we have the dystrophin protein in the brain, in the muscle, Purkinje cells, retina isoform, and Schwann cells, and general isoform. We can see that it's also presented in the liver, brain, cardiac muscles. Sorry. We have the dystrophin is presented in many tissues in the our body system. Clinical presentation, usually the onset of Duchenne muscle dystrophy begins before the age of 6 years, around 2 to 3 years. There is proximal muscle weakness presented by repeated falling, difficulty in climbing stairs, clumsy gait, difficulty in getting up from the floor, positive Gauss sign, and tiptoe walking with waddling gait. Clinically, the patient may have hypotonia, waddling gait, hyporeflexia, calf muscle pseudohypertrophy, and exaggerated lumbar lordosis. There is progressive weakness, and patients become bound to the wheelchair almost by the age of 12 years. Muscles are atrophied and become replaced by fibrous tissue, which leads to muscle shortening, fibrosis, and contracture deformity at the end. By the age of 14 to 15 years, cardiomyopathy is a common feature. Scoliosis resulting in impaired pulmonary function, which can eventually cause acute respiratory failure and is a cause of death. The characteristic maneuver of climbing up the thighs while standing up with the aid of their hands to overcome the weakness of the pelvic and proximal lower limb muscles, first described in 1979 by neurologist William Richard Gowers, caused by heredity and less likely acquired causes. So the positive Gowers sign is not a diagnostic of Duchenne. It's one of the signs of Duchenne and can present it in other proximal muscle weakness. You can see that he's extending his lower limb, so he's going to climb himself now because he cannot do the anti-gravity extension. This is one of our patients at the National Research Center. One of the signs you will see at the end of the video that they have large protruded tongue, because the tongue is one of the muscles, so it becomes hypertrophied. The other clinical manifestations that may be presented in Duchenne muscle dystrophy is intellectual disability, which is present in 27% of the boys, learning disability by 44% of the boys. Other psychiatric disorders may have attention deficit hyperactivity disorder, and anxiety and autistic spectrum disorder. Complete diagnosis involves clinical examination and patient's medical and family history. We should ask about any other affected family members, especially from the maternal side. Blood test, CPK, creatine kinase, is very sensitive. It can be elevated in the newborns. So it can be used as a screening tool for muscle dystrophy. And serum transaminases, because it's one of the isoforms is present in the liver. EMG, you will see myopathic pattern. Muscle biopsy is now became obsolete. You can see muscle myofiber degeneration with fibrosis and fatty infiltration on muscle biopsy. Muscle biopsy with immunohistochemical staining, you can see deficient dystrophin gene. But we use muscle biopsy now on a research base to see the effect of treatment on the muscle and expression of the dystrophin protein. Then the genetic test to confirm the type of mutation, which is a very important tool in the diagnosis. So from the pedigree, you can see that the pattern is X-linked recessive. In this movement, you can see it goes up and one to the side, one up to the side. We called it in the chest the night move. حركة الحصان في الشطرنج تطلع خطوتين وتتحرك يمين أو شمال. So this is the night move in the chest. In the family pedigree, you can see it. It's an X-linked recessive. That means that when the mother is a carrier, it can transmit the disease to her male offsprings, and her daughters may also have the chance to be carrier. But if the father is affected, like in Baker muscle dystrophy, he doesn't transmit the disease to his male offsprings, but he transmits it as a carrier to his female offsprings. This is a simple algorithm for diagnosing Duchenne muscle dystrophy or Baker muscle dystrophy. If you have a high CPK and you have a male affected only in the family, you should suspect as Duchenne muscle dystrophy. You go for MELPA for Duchenne, because MELPA helps us in diagnosing the most common mutations, which are the deletion and duplication mutations. It can give us a diagnosis in about 70 to 80% of cases. The other percent of cases, 20 to 30%, is due to point mutations, which needs either sequencing the dystrophin gene by Sanger or NGS. If there is a positive consanguinity and females affected, you should think in autosomal recessive limb-girdle muscle dystrophy, and you can ask for myopathy panel or whole exome sequencing. Genetic testing for Duchenne muscle dystrophy. We used to do in the past the multiplex PCR, which detects deletions, only mutations in the major and minor hotspots covering 18 exons. It's a simple test, but it doesn't cover the duplications and deletions out of the hotspots. The MELPA diagnoses deletion and duplication all over the dystrophin gene. And if it's MELPA negative, we do the Duchenne muscle dystrophy sequencing by Sanger or by next generation sequencing. Types of mutations in the dystrophin gene. Mutations abolishes dystrophin function either by disrupting the reading frame or by generating a premature stop codon. The most common changes in dystrophin are intragenic deletions, which account for 65% of dystrophin mutations. Two deletion hotspots are known, one located towards the central part of the gene, which is most common, exon 45 to 55, and the other towards the 5' end, including exons 2 to 19, with genomic breakpoints commonly found in introns 2 and 7. The frequency of duplications may range from 5 to 15%. So when we count for 15 and 65, we can reach to 80% diagnosis by MLPA. The remaining cases are thought to be caused by combination of small mutations, most commonly point mutations resulting in nonsense or frame shift mutations, pure intronic deletions, or exonic insertions of a repetitive sequence. Deletions shift the reading frame of the dystrophin gene, resulting in premature stop codons that leads to unstable RNA transcripts, and truncated proteins are subjected to degradation. There is no simple relation between the size of the deletion and the resultant clinical disease. That means that small deletion of a small exon may result in Duchenne muscle dystrophy. However, the deletion have been described in large deletions have been described in Baker muscle dystrophy. The effect of the phenotype depends, therefore, not on so much extent of deletions, and the same applies for duplications, but on whether or not it disrupts the reading frame. So the size doesn't matter, the reading frame only matters for the phenotype. Mutations that maintain the reading frame in frame generally results in abnormal but partly functional dystrophin and are associated with Baker muscle dystrophy. 20 to 35% of patients with Duchenne muscle dystrophy and Baker muscle dystrophy do not have deletions or duplications of the dystrophin gene. Most of the mutations so far identified in patients with Duchenne muscle dystrophy are nonsense point mutation or small frame shifted deletions or insertion, intronic splice site, and 5' and 3' untranslated regions mutations have been also reported. You can see from the first, this is the normal dystrophin. The second one, when there is deletion of exon 4, you can maintain the frame, so it is called in frame. When there is a deletion of from exon 7 to exon 11, when you can maintain the in frame translation, but when you have exon 7 deletion only, there will be out frame that leads to disruption of the translation of the protein. Can patients with the Baker muscle dystrophy with frame shift mutations have several well-characterized deletions or duplications. Exoskipping allows these patients to produce at least some dystrophin, which occurs via alternative splicing. The carboxy terminus is always preserved in these patients. The type of mutations, you can see the first one is an intronic mutation. The second one is deletion of exon 45 to 50. Third one is a stop mutation. This is a stop mutation, nonsense mutation. This is also a nonsense mutation. All these are diagnosed by Sanger sequencing, and this is diagnosed by MELPA. There is duplication of exon 8 to 11, deletion of exon 45, 5 to 44, which is a large deletion, duplication of exon 2, and lastly, homozygous deletion of exon 3 to 34. Thank you.
دكتور محمود، طبعا انا برضو اعرف دكتور محمود من حوالي 15-20 سنه كده. الف شكر ليك، كل شغلك فعلا كان فتره طويله قوي مع الدوشان، والنهارده يعني اديتنا يعني حاجه كده دسمه ودخلت بينا في الجينيتكس، فان شاء الله كده تبقى يعني بدايه كده العلاجات، كل الجينيتك ميوتيشنز دي عشان بدايه للعلاجات الحديثه باذن الله. الف شكر دكتور محمود.
طبعا انا احب اقدم الدكتوره ناجيه بخبرتها الطويلة قوي 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 في النيوروماسكولار ديس اوردر. الحقيقة يعني عطائها للموضوع دون بصراحة يعني بكل حواسها في كل المجالات اللي لهم علاقة بالنيوروماسكولار ديس اوردر. الدكتورة ناجية هتتكلم على update of therapy of Duchenne muscle dystrophy.
ألف شكر دكتورة مها وفريق الناشونال ريسيرش سنتر اللي دايما بيساعدنا في التشخيص المرضى وتوجيهنا. احنا طبعا لازم نبتدي نعرف الابديتس اوف ثيرابي اوف دوشين ماسكولار ديستروفي. دكتور محمود ادانا البدايه اللي احنا عايزين نعرفها. طبعا زي ما عرفنا دلوقتي ان الدوشين هو الموست common and well known genetic disorder affecting at least 1 in 3,500 live male births, and it is the commonest type of muscular dystrophy. That's why other patients told me, why you are concentrating on Duchenne and leaving other type of muscular dystrophy? Because it is the most common type. And Duchenne phenotype, as we already see, is a boy, usually with delayed motor milestones of development, has proximal weakness of both lower limbs before 5 years of age with calf pseudohypertrophy and a very high total CK. If you have this phenotype, we must think about DMD until proved otherwise. We don't want to wait to have this phenotype already described to us by Dr. Mahmoud Yusri. We want to diagnose our patient very early. We want to diagnose before the fibrosis and the marked weakness and the Gower sign. We want to diagnose before the cardiomyopathy, because if we waited to this, he will not improve. That's why some of the recent genetic interventions, many doctors informed it is not effective. Yes, it will not be effective at that stage. Can we diagnose Duchenne very early? Yes. We must search for early delayed milestones of development, especially delayed motor milestones, delayed language, cognitive functions. And also, if there is a family history of X-linked disease or of Duchenne muscular dystrophy, he is diagnosed that he is Duchenne muscular dystrophy, we must diagnose that child very early. One more, we can diagnose by CK level. If we did CK level very early, even after birth, we can diagnose Duchenne muscular dystrophy. So as already explained by Professor Mahmoud Yusri, dystrophin gene was sequenced by Konkel et al. 1986, and it is a very big gene, XP21, and 79 exons, and to give us this protein, the large protein. And also, we know that the dystrophin is critical to the structure and stability of all muscles, including skeletal muscle, cardiac muscle, respiratory muscle, and it is also crucial for the brain, as already explained. So it will link the cytoskeleton to the extracellular matrix by connecting the actin network to the dystroglycan localized in the sarcolemma membrane. The absence of this dystrophin will lead to sarcolemmal fragility, muscle weakness, and necrosis. And also it is explained that it is an X-linked inheritance, and boys 50% are affected and 50% of females are affected. So it is a disease primarily affect boys, and there are female carriers that may show symptoms, but Duchenne in females is very, very rare. And the incidence, as we already mentioned, 1 to 3,500. It could be up to 5,000 live male births. Globally, we have diagnosed of 20,000 children are diagnosed with Duchenne each year. I think it is not anymore a rare disease because of accumulation of cases. So, as already mentioned, dystrophinopathy is the most common type of muscular dystrophy. Muscular dystrophy can comprise up to 30 inherited diseases or more, but Duchenne is the most common, representing more than 50% of cases. That's why all therapeutic interventions are going to Duchenne. So, dystrophinopathy is a spectrum of muscle diseases. It's not only a one disease, with symptoms that range from severity, from mild to severe. As we know, this is the spectrum of this dystrophinopathy. In the mild arm, the mild part, it could be asymptomatic, high CK, or asymptomatic female carrier. But we have muscle cramps with myoglobinuria, the Becker, muscular dystrophy, the Duchenne, the most severe form, the Duchenne muscular dystrophy. Also, we have intermediate form, and we have, could be either isolated or associated dilated cardiomyopathy, asymptomatic female carrier, or asymptomatic female carrier. All of this is a spectrum. So it is a rare disease, but it is a severe and it is a fatal disorder. Here are the deletions explained by Dr. Mahmoud. We have more than 68% are due to large deletions or large deletions, and 11 to 15% are large duplication. We have other small mutations. 10 to 15% is what is called nonsense mutation, and this is very important for the therapy, and about 20% other small mutations. So, urgency of early diagnosis in Duchenne is very important. How can we suspect Duchenne? We suspect Duchenne by observation of the abnormal muscle function. If there is a gross motor delay, if there is a gait problems, if started tip to walking or Gower sign, but I want to diagnose very early. And also, if we have a boy with this at any age and we did the CK level and found it elevated, of course I will not do the muscle, I will not wait to do the muscle biopsy. If we suspect dystrophinopathy, it needs to be confirmed immediately by accurate genetic testing. Now, we don't do muscle biopsy. We do first the genetic testing. First, the MLPA. If it is negative, we do sequencing. If it is negative and we are sure of the X-linked inheritance, we go to muscle biopsy. If we find the dystrophin is negative, sometimes we have 2 patients now, we did whole genome and we found the mutation. So, diagnosis, as we know, is frequently delayed. It is hypocalcemia. He is still not known how to walk. We will do for him physiotherapy, so it is delayed. But if we found the CK from the start, I even asked to do CK with neonatal screening. If we found high CK with neonatal screening, we can diagnose all types of muscular dystrophies. Why we don't do this? So, as we said, with the developmental delay, not only the motor, they delayed language, reading, smiling. Even delayed bowel and bladder training became to be with the early developmental delay. So, the timeline of diagnostic steps for patients, as you see, 2.5 years, the earliest signs appear. 3.5 years, there is physician evaluation by healthcare practitioner. And 4.6 years for the first a pediatric neurology or a neuromuscular visit. There is a delay of 2.5 years. 4.7 years, just the first CK to be done, and 4.9 years, or at 5 years, we diagnose Duchenne. We have a 3 years delay in diagnosis Duchenne. That's why the drugs are not effective. We must diagnose very early here, or even I want to do a diagnosis with birth. So, of any suspicion, ask about family history, do CK, any suspicion, do CK, and do the genetic testing. We don't do muscle biopsy. We will do muscle biopsy after all the genetic testing are negative. What is the therapeutic approaches of GMD? Until now, most of pediatricians refuse to give steroids, corticosteroids. It is the main treatment. And if many doctors like me handling Duchenne patients, they know the difference between a boy taking steroids and a boy doesn't take steroids, a great difference. There is marked deterioration of his motor function and the marked deterioration and contractures and early complication. So steroids is still the main therapy. Don't forget the multidisciplinary team. We will have half day today about all the multidisciplinary team. This is very crucial for therapy. Even if we give gene therapy, no improvement without the multidisciplinary team at all disease stages, including physiotherapy, rehabilitation. Don't forget the steroids, as already mentioned. There is occupational speech and language to prevent contractures, and it is very important, the nutrition, the cardiac, the pulmonary. So what is the therapeutic approaches now in development for Duchenne muscular dystrophy? We have either dystrophin restoration approach or other approaches. Dystrophin restoration approaches include the in-frame nonsense mutation, read-through. So this we have a treatment to read through for this premature stop codon, ataluren or Translarna. We have exon skipping therapy. Now we have synthetically modified DNA or RNA antisense oligonucleotide. This is the name. So they promote exon skipping to restore the functional dystrophin protein expression for types of large deletions or duplications. Now we have 4 companies at least working on gene therapy, viral and non-viral, introduction of a functional dystrophin gene directly into the muscle fibers to restore the sufficient levels of expression. Also, there is some drugs working on the skeletal mass size, like the NFXB, is activated in skeletal muscles from patients with Duchenne, and if we do inhibition, may decrease inflammation and may favor muscle regeneration. This is also still under clinical trials. So I will explain these drugs rapidly. We have PTC company, PTC Therapeutics. In 2014, we have the ataluren or Translarna, a drug for nonsense mutation. This premature stop codon, it will lead to read-through and will have restoration of the dystrophin. Sarepta has 3 drugs. Sarepta in 2016 took approval of Exondys 51, the eteplirsen, and then in 2019 took approval of Vyondys 53 or Golodorsin, and NS Pharma in 2020 also took approval for Viltolarsen, another exon skipping 53, and also lastly Sarepta 2021 took approval for Casimersen or Amondys 45. So these emergent therapies, there's sufficient changes. Ataluren is a very important drug. Until now, it is EMA, European approval, not FDA approval in United States. As you see, there are points of normal stop codon, but it works on premature stop codon mutations, the nonsense mutation, and this occurs in 10 to 50% for patients 2 years or more. And ataluren reads through. This is an explanation for the drug, and it will selectively enable premature stop codon and not for the out frame. It is for the in-frame premature stop codon or in-frame nonsense mutation. It will lead through a premature stop codon to enable complete translation to the messenger RNA into the functional protein. Ataluren is a read-through agent, again for nonsense mutation. It binds to ribosome and reads through a premature stop codon caused by a nonsense mutation to produce a full-length functional protein. It has high specificity and not the normal stop codon, but the premature stop codon. And it is very important that it is not indicated for a frame shift mutation, because we have a case like this with Dr. Nermeen, and the company said it is not indicated for stop codon caused by a frame shift mutation. So this is one of my patients.
اقعد يا حبيبي.
Sorry.
يلا قوم كمان مرة. شاطر. يلا روح عند الستارة هناك.
Sorry. Okay, can you promote? Okay, I'm sorry. This is one of my patients. I had heard about clinical trial in 14 European countries. I asked that Egypt will enter in this trial. They refused. Then they permitted to send 8 patients on their own responsibility. 4 of them are already treated. This boy is Duchenne muscular dystrophy, 10.5 years old, and he is being on ataluren in the clinical trial for 3 years, 1.5 therapy and 1.5 placebo. But if you find this child, I'll just remove the sound. You see him. You see? No Gawar sign. There is no Gawar sign. He can sit and he can stand very easily. 10.5 years old nonsense mutation. I want you that you will see he's walking. Okay. This is a walking of the child, 10.5 years old. He's under steroids. When he come back to me after the clinical trial, I was surprised. He is very good. Okay, so this is for the nonsense mutation. What about the exon skipping therapy? Exon skipping therapy, the first one approved in 2016 is eteplirsen or Exondys 51. It is FDA approved, but not EMA approved, so it is not approved in Europe yet. And for the mutations amenable to exon 5 skipping, that it will cover 10 to 15% of patients. As you see, this is a dystrophin gene, the exon map, and the most common hotspots are from 45 to 55 exons. So Sarepta company started to work on this part that represent hotspots, most of the patients with deletion. So the principle of exon skipping involves the correction of a genetic reading by skipping an exon to allow ribosome to produce a truncated but functional protein. What eteplirsen do? Eteplirsen will bind to exon 51 and remove it from function, as this is again the dystrophin gene or exon map. This is exon 1 and this is exon 79. As you see, some exons are connected with a line and some exons are connected like this or like this. If all the exons fit together, so the genetic so the protein will be produced. If there is a mutation, a deletion, or duplication, so the protein will not produce. What exon 51 do? If you have here a mutation, 48, 49, and 50 are not present, so exon 47 cannot fit with exon 51. This is a common mutation, a hotspot mutation. So we have these antisense oligonucleotides. They made will catch or will hold to exon 51, and then it will non-function. So exon 47 can continue the reading with exon 52. So we will have protein. This protein is shorter, this protein is truncated, but it is a functioning protein. As if I am transforming a Duchenne to a Becker. If we give this drug very early, it will give effect. If we give it late, after 5 years, 7 years, after loss of ambulation, no effect. So this is the theory of exon skipping theory, because I heard one of my colleagues and patients saying that exon 51 was to patients who have deletions of exon 51. This is completely wrong. It will be to those exon deletions and mutations around exon 51 and are amenable. There is a table which the genes are amenable to 51. So exon 51 skipping again, this is the normal protein and normal dystrophin, normal gene and normal protein. Then this is if there is a deletion of 48 to 50, here there is a deletion. So we have to remove 51 from working by the antisense oligonucleotides. Then we will restore again the messenger RNA, and we will restore the protein. This is the idea. Okay? Another, in 2020, we have the golodorsin or the exondys 53, the same idea. It will work for patients with deletions amenable to exon 53. And again, we have the casimersen, the last one, in 2021. All of these are FDA approved, but not EMA approved, and it is for exon skipping 45 in about 88% of patients. And, sorry, I have one last slide. Okay, this is the most important, and this is what we are waiting for. Because of the selective gene therapies for Duchenne muscular dystrophy, we have 4 companies at least working now. The Sarepta company, it will work in a molecule and for gene transfer, microdystrophin transfer, and data is expected early next year. They are in phase 3. And Pfizer is in many countries now, in Saudi Arabia, and they are in phase 3. They started already. Solid, they clear to resume new patients again, enrolling next year, and Astellas expected to start in December again. So we are waiting for this gene therapy. But last comment that number 1, early diagnosis. We have to do neonatal screening and search for CK level very early, especially in high-risk families. Number 2, the early diagnosis, the delayed motor milestones, the delayed language, pseudo-hypertrophy in a boy, CK until proved otherwise. We don't do muscle biopsy. We do MELPA, the MLPA of dystrophin gene. If negative, we do the dystrophin gene sequencing. It is done by NGS now. If negative, and we are sure it is a dystrophinopathy or another muscular dystrophy, we have to do muscle biopsy, histochemistry, and immunohistochemistry. If it is dystrophinopathy, even we did whole genome for 2 patients. Thank you so much.
Thank you very much, Dr. Ragia, for this very comprehensive and overview on Duchenne muscle dystrophy, especially on the treatment and the methodology of treatment and the idea of treatment. Thank you very much. We will postpone all questions after finishing the session. Preparing يعني حضروا الأسئلة. أي حد عاوز حاجة بعد السيشن إن شاء الله يعني في نهاية السيشن نشوف الأسئلة إذا كان في حد محتاج حاجة. Now I will present a dear colleague a clinical geneticist like me, Dr. Nermeen Salah. She is one of the eminent working on genetics of muscle dystrophy in Shams University. She will talk about dystrophinopathies in a female.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Maha, for your elegant presentation. And I would like to thank also Professor Nagia for her invitation. And I am happy to share with you today the topic of dystrophinopathy in females. Our principal points will be definition and terminology and the classification. Next, how does a girl become a carrier? How can a girl pass the pathogenic variant to her children? The clinical spectrum of dystrophinopathy in females, and why it is very important for a female to know that she is a carrier. As you all know, the last week it was the celebration of the 8th World Duchenne Awareness Day in September 7. And on this day, all the specialists raised awareness for the Duchenne around the globe. As every year, there is a special team that deserves more attention. This year, the theme was Women and Duchenne. Again, as you all know, following the diagnosis of DMD in a male child, all the focus is on the child and not on the possibly carrier mother, who often don't have time to look after themselves or their health needs. So the aim of our presentation today is to highlight the need for special attention to this group of population. To start with the definition of dystrophinopathy, it refers to the spectrum of diseases caused by mutation of the DMD gene. And the definition of a carrier generally, it is a person who carries a genetic mutation or genetic pathogenic variant in any of their genes that could be passed on to their children. And according to the European Neuromuscular Center workshop, the current term used to describe asymptomatic women, including DMD carrier and manifesting carrier, are not appropriate to the women affected. They recommend the term carrier, that the term carrier to be reserved to the female carrying a DMD pathogenic variant, and they are asymptomatic and with normal investigations. For females in whom there is evidence of clinical involvement, the term manifesting carrier was not felt to be appropriate. Instead, they recommend such women would be better described as female patients with dystrophinopathy, including female patients either with muscular dystrophy and or cardiomyopathy caused by the dystrophinopathy. There are 3 accepted categories of carriers proposed by Professor Emery and Professor Mentoni based on the genetic consideration. First, the definite or the obligate carrier, who are the mothers of an affected son, but also they have an affected brother or affected nephew by sisters, or an affected maternal uncle, or any affected male on the maternal line. The probable carrier, who are mothers with 2 or more affected relatives, or 2 or more affected sons, and there is no any other positive family history. And in this condition, the germline mosaicism will be a great possibility. And finally, the possible carrier, where mothers of a single affected son, as well as their sisters or other female relatives. Now we will discuss how does a girl become a carrier of DMD and how can a girl pass the pathogenic variant to her children. As we all know that the dystrophin gene that causes the DMD is located on the X chromosome, which is one of the 2 sex chromosomes. Usually we have in males the X and the Y, and the female has 2 X chromosomes. As the girl has 2 X chromosomes, so she has 2 copies of the dystrophin genes. So if one is mutated, she can fall back on the other. But in male, he has only 1 copy of the dystrophin gene, as he has only 1 X chromosome. So if this chromosome is mutated, he has no other copy to fall back on. How does a girl become a carrier? This may occur either by inheritance from the mother or by inheritance from the father. We start by the inheritance from the mother. Here we have a father, he has normal X, and the mother has 1 normal and 1 affected X. If she transmits the affected X to her daughter with the normal X of the father, so the daughter will be a carrier from the derived diseased X from the mother. The inheritance may occur also from the father if he has a Baker disease, as the patients with Baker can give children. Here the father has mutated X and the mother has 2 normal X, and she receives the diseased X from her father and the normal X from her mother. So how can the girl, after being a carrier, can pass the pathogenic variant to her children? Here we can draw the Punnett square, and we have here the father who has 2 gametes, the Y and the X, and the mother has the normal X and the mutated X as she is a carrier. We have the first, because لو احنا بنتكلم على X-linked disorders, يبقى لما اجي اتكلم على الجيناتيك كونسلنج لازم لو الام بتقول لي الحمل الجاي هيحصل ايه، لازم اقول لها لو ولد هيحصل كذا ولو بنت هيحصل كذا. لازم اسبيسيفاي الجيناتيك كونسلنج according الى كان boy or girl. So if he is a boy, she has 55%. عندي normal Y مع normal X يبقى 50% to have a normal boy. She have 50% to have an affected boy. Then for the girl, she has 50% to have a normal girl, normal X with normal X, and she have 50% to have a carrier girl. And overall, she has 25% to have an affected boy, as each box represents 25%. The clinical spectrum of dystrophinopathy in females. Females who carry a DMD gene pathogenic variant can present by a spectrum of features. First, if she has 2 normal dystrophin genes, she will be normal. If she has 1 normal and 1 mutated gene, she has a spectrum of either asymptomatic or asymptomatic at the level of the phenotype and the investigations. Or she may be asymptomatic as the clinical base, but she has elevated CPK, or it may be a manifesting carrier, that means she has a muscular and cardiac involvement. And finally, if the female has the 2X mutated, she will be like the boy. She didn't have any functioning copy, so she will express the DMD full picture. And we can tell her also classic dystrophinopathy. Why is so much variability؟ يعني ليه الفيميلز بتيجي بكذا شكل مش زي الولد دوشين وخلاص؟ ليه يا اما اسيمتوماتيك يا اما تبقى كارير والسي بي كي بس هو اللي عالي، او كارير والفي muscular and cardiac involvement؟ أول سبب the process of X inactivation. As we all know, the male has 1 X chromosome and the female has 2 X chromosome. So in order to compensate for the double dosage of genes in the female, during the fetal life, the woman get X inactivation of 1 of her X's. يعني الفيميل علشان تتساوى بالميل في الجينز اللي على الإكس كروموزوم، لأن بعد كده بيحصل كروسنج أوفر وبيتبادلوا الصفات بين الأب والأم، فلازم يتعمل inactivation لواحدة من الأكسس. فاللي بيحصل إيه؟ إن الموضوع ده بيحصل طبيعي راندوم. كل عضو من أعضاء جسمنا بيحصل inactivation لوان اكس أيا كانت، اللي هي derived from the father أو اللي derived from المother. لو in case of Duchenne نشوف هنا لو الموضوع بيحصل inactivation random وبشكل طبيعي، هيبقى عندنا equal number or relatively equal number of the normal X and the diseased X. And so half of the muscle cells make functional dystrophin and typically healthy and functional muscle. وفي الحالة دي بتكون عندنا الفيميل عندها بتبقى asymptomatic. لكن لو حصل حاجة اسمها non-random، يعني حصل inactivation للنورمال X واللي فضلت active هي الديزيزد X. we have a great proportion of the diseased X relative to the normal X, so most of the muscle cells don't make dystrophin, and this result in muscle and heart affection. This is the first cause. The second cause, here there is a difference ما بين الراندوم inactivation والnon-random inactivation. هنا المسل بتكون severely affected. Second cause, the presence of modifier genes. ده ملوش علاقة بقى خالص بالإكس inactivation، ده process تاني. في genes other than dystrophin. It will combine with the pathogenic variant in the DMD and lead to further inflammation. ايه هو الموديفاير جينز؟ دي جينز تانية غير بتاعة الدوشين، لكن بتتحد مع الابنورمال ديستروفين وبتخلي الحالة تسوء أكتر. طيب واي برضو there is في variable much variability؟ لما بيكون في 2x affected بتبقى الفيميل عندها الفول بيكتشر اوف الدوشين looks like الميل بالظبط. There are 3 accepted categories of Why it is important for a female to know that she is a carrier? First, for her own health. Second, for family planning. And third, for her relatives. For her health, because the carriers have increased chance of heart disease and muscular affection. So if she is known that she is a carrier, she should be evaluated regularly by her doctor who is familiar with Duchenne. And regular cardiology appointments are necessary and referral to other specialists may be needed. Secondly, the family planning. The carrier have increased chance of having children with Duchenne, as we have discussed. So the woman who is carrier can make more informed plan and choose any productive option available, such as we allow the normal pregnancy without any intervention, or we allow the normal pregnancy and then we do the sex determination followed by determination of mutation if the familial mutation was known. Or we do the natural pregnancy determination of sex and linkage testing if the mutation was not known. And finally, we have the pre-implantation genetic diagnosis. Third, why it is important for the female to know that she is a carrier for her relatives, as once a carrier is identified, in a family, there could be several carriers identified, and in this regard, it is important to share this information with the females so they can pursue carrier testing if desired. And this is an example of the male diagnosed with Duchenne. He has deletion of several exons, and the molecular diagnosis has confirmed that his mother is carrier of the same mutation. Final conclusion and recommendation is it is important and the carrier need increased awareness for the carrier of their potential developing symptoms and for the healthcare professional to give them the preventive measure available. And my takeaway message that every Duchenne carrier with dystrophinopathy showing symptoms or not needs regular medical checks and should receive support. Thank you.
شكرا جدا. Thank you very much دكتورة نرمين for this very interesting presentation. يعني كارير فيميل ده شيء مهم جدا. هي أهم حاجة بالنسبة لنا كجينيتيست الجينيتك كونسلنج which is very important. يعني كتير قوي من الناس تقول احنا بنشخصه ليه؟ لا بنشخصه عشان هم هيجيبوا ولاد تانيين مرضى يبقى عندهم 3 4 عيانين بنفس المرض، فده مهم جدا. لا ما لسه ما فيش علاج او لسه في علاج، ده بتكلم الجنرال الجينيتك ديزيز جينيتك. فمش بس الماسل ديستروفي او النيوروماسكولار ديس اوردر، لكل الجينيتكس التشخيص مهم جدا جدا عشان الفاميلي بلاننج، وعلشان نقدر نقول لهم هنعمل ايه او الحاله دي هتوصل لايه. انا عندي بس اضافه صغيره على محاضره الدكتوره نرمين، ان انا مش بتكلم على المذر اللي هي الكارير، انا بتكلم على الفيميل ان ممكن تكون فيميل افكتد وهي تيرنر سيندروم، عندها سنجل اكس، فبالتالي طبعا دي مش هتخلف بس هي عندها سنجل اكس. فاحنا لو لقينا المانيفستيشن ان طبعا ان هي ريتاردد او شورت ستيتشر او كده we should do karyotyping first عشان to exclude Turner syndrome، لانها ما عندهاش الاكس الثانيه we should do karyotyping first. ده لو هي صغيره يعني، لكن طبعا لو هي ماذر طبعا دي قصه تختلف تماما. بشكرك جدا. طبعا I would like to thank Professor Nagia, Dr. Nermeen, Dr. Mahmoud for their excellent presentations. Any question لو كان في حد محتاج أسئلة؟ دكتور محمود.
السلام عليكم وشكرا على المحاضرات الجميلة قوي دي. سؤالي لحضرتك يا دكتورة ناجية، بتكلم على الدوشين. بقول لحضرتك what's about time و duration و dose of corticosteroid on Duchenne patient and what's general workup during the therapy and how to protect the patient from corticosteroid complication اللي هي واحد منها ان هي هيجيله secondary ما يوصي.
هو حضرتك هو دلوقتي خلاص في الستاندردز اوف كير محطوط الاستيرويدز نمبر 1 ثيرابي للدوشان. once diagnosed we start الديفلازاكورت اول موجود في مصر باسم فلازاكور، احنا بندي 0.9 ملي بير كي جي وبنديه ديلي، ما بقيناش بندي alternate day، لا بنديه ديلي. الحقيقه انا ما ببتديش بالفول دوز، يعني انا دايما ببتدي بسمول دوز واطلع بيها كل شهرين 3 وخصوصا لما يبقى لسه صغير. البريدنيزولون 0.75 ملي بير كي جي، جرعه اقل شويه. الفولو اب از امبورتنت، فحضرتك لازم الدكتور اللي هو المعالج he must see the patient every 3 months at first 1 or 2 years. After this we can see every 6 months. We do usually follow up blood sugar, blood glucose, we do follow up CK and other lab, body weight every month, and we give restrictions for the diets or there will be a dietitian with us. Physiotherapy, we do physiotherapy at least 2 to 3 times per week, non-exhausting, not so long duration, 30 minutes is enough. Swimming is very nice if there is swimming, especially early 1 or 2 times per week. We found our patients without steroids, without physiotherapy are deteriorating. Of course, cardiac assessment every 6 months to 1 year early, then after 10 years it must be every 6 months. Pulmonary function test after 10 years we do every 6 months. But this is mandatory. We have to do this protocol.
شكرا جزيلا دكتورة ناجية.
انا مش هسال سؤال، انا كنت عايز to give the credit to Professor دكتور عماد فضلي الله يرحمه. هو كان بيدي ستيرويدز من الثمانينات وكان بيدي STH وكان guided بالسي بي كي، ف
Yes.
I should give him the credit for
Professor
this.
Ahmad Fadli, our mentor, the very, very excellent neurologist. He was giving steroids and STH, and all of us were criticizing him. But he said the muscle has inflammatory process, so we must give steroids to guard against further fibrosis. And it is proved that he is right. تفضل فندم.
شكرا دكتور ناجية وشكرا على المؤتمر الجميل ده. حضرتك طبعا الدوشين ايرلي هفرقوا ازاي بين السي بي؟ انت حضرتك ركزت قوي على الدوشين ان هو بيجي بالكوجنيتيف امبيرمنت وسبيتش ديليد سبيتش، اعتقد ده يمشي اكتر مع السي بي. فانا تنصحي بقى ان كل واحد ديليد ميديسون هعمل له سي بي كي عشان اقول ده
والله يا فندم انا
سي
فعلا
بي ولا دوشين؟
انا طلبت فعلا لما كانوا في وزاره الصحه بيحطوا بروتوكولات in neonatal screening. I asked for CK level with delayed motor milestones of development. Then I found in some states they asked for this. It's a very cheap test واحنا بناخد البلاد تيست من البيبي ممكن نعمل، ولكن زي ما دكتور محمود يسري كده ورانا ما عندوش جوار ساين، يعني برضو الجوار ساين بيبان فيري ايرلي. ما عندوش، بص تلاقي حضرتك السي بي رايح وجاي ما عندوش اي مشكله. ما عندوش الكاف سودو هايبرتروفي it appears very early. The calf pseudohypertrophy, the type 2 walking, and the high CK appears very early, together with the delayed motor milestones. In more than 50% of patients, delayed language, it is present in a large number of patients. So
اعتقد دكتور ناجية نوت كومن قوي في الدوشين اللانجوج ديليد والكوجنيشن، وده والسي بي مور ذان دوشين. يعني لو انا هاجي اقول ككلينيكال ديليد سبيتش او ديليد كوجنيشن ده مع السي بي ديليد، انما الدوشين غالبا موتور، فده يعني برضو مش
لا للاسف حضرتك الكلام ده طلع مش مظبوط. ودلوقتي في بروجكت كبير قوي في اوروبا وامريكا دوشان and brain, and we even found autism, started autism, he is dystrophinopathy. ADHD proved to be dystrophinopathy. So now after genetic study all over the world, the Duchenne as a disease is completely changed. تفضل. المايك.
First of all, thank you, Professor Nagia, for this marvelous conference. Based upon your great experience as regards the new medications for the muscle dystrophies, how far do you find that some of the new medications is quite superior to treat the complication rather than another one? I mean that one medication could be much more superior to treat the cardiomyopathy associated with Duchenne rather than other one. Is there any data about this? يعني في دواء منهم ممكن يكون أكثر فعالية في علاج الcomplication associated with Duchenne as
The new genetic drugs? No.
ما فيش لسه
Not yet.
So
the new genetic drugs, no.
They are all equal.
But they didn't mention yet any effect on differences in cardiac affection.
Yeah.
But in our team, we have the cardiologists. Sometimes we give a protection. Sometimes like calcium channel blocker or some drugs we give as a protective from cardiomyopathy. But at the genetic level, I don't know about any changes in the types of drugs regarding cardiomyopathy.
شكرا. Thank you.
Okay.
لو البيشنت ماشي على steroids suddenly he became diabetic. I have two patients with that.
Okay. Fortunately, we know this and we are following up our patients. If we found that he became diabetic, it's according to the degree. If it is the glucose level is very low, can be controlled by diet, it's okay. If he needs therapy, I usually withdraw steroids.
Just I want to add something regarding the involvement of the heart. It's usually with the Becker muscular dystrophy. And in the Duchenne, we start the therapy early before development of cardiac lesion. But in Baker, the cardiac lesion may start early, and for Baker, there is no mutation-specific therapy because usually the mutation is in-frame mutation, and the therapy is for the out-frame to be corrected to the in-frame.
شكرا جزيلا. Thank you.
I think we have to close this session. Thank you so much. And chairpersons for the second session, Professor Osama Abdelghani, Ain Shams University, Professor Magdi Aidarouz, Zagazig University, Professor Iman El-Marakbi, Ain Shams University, and Professor Mohammed Hamdi, Ain Shams University. Thank you. هيبقى في حضرتك اكسشينج ساره خلاص قالت خلاص بروفيسور لودولف هيقول
بسم الله الرحمن الرحيم. نبدأ الجلسة الثانية في مؤتمر اليوم. في البداية طبعا أنا بحب أشكر جدا الدكتورة ناجية والتيم اللي معاها اللي حطوا المصل ديزيز على الخريطة. سنوات طويلة الدكتورة ناجية كانت بتكافح لوحدها الواقع وبتحارب لوحدها، لكن لكل مجتهد نصيب. ربنا في الآخر جزاها خير على كل اللي عملته، واعتقد ان معاها دلوقتي تيم جميل وعظيم من الطبيبات الصغيرات السن زي رضوى اللي طالعه تتنطط كده وتقول لنا يعني هنغير. اوكي دكتور القط الاول، دكتور قط الاول اللي تقدمه خلاص، هي الساعه الاول انت اللي هتقدميه. وبنبارك لها طبعا على المؤتمر الثالث عقبال ما يبقى ال30 ان شاء الله، والسكول الثالثه بردك. وان شاء الله يعني زي ما المجموعه بتاعتك بتكبر هتكبر المهتمين بهذه الامراض، ودايما الاهتمام بالمرض بيجي اكتر لما يكون له علاج الواقع يعني. وعشان العلاجات طبعا ابتدت في السنوات الاخيره تبقى كبيره، صحيح غاليه لكن كبيره، لكن الدكتوره ناجي هتنيها وراهم كده ناجنج كده لحد ما تخلي كل المرضى دول ان شاء الله ياخدوا فرصتهم في العلاج، وربنا الشافي باذن الله. انا هسيب بقى الدكتوره ايمان تقدم الفيرست سبيكر دكتور بيرن اود. اتفضلي يا دكتور ايمان.
I would like to introduce Professor Byron Oud from Temple University. He will talk about diagnostic approach of muscular dystrophy. Professor Byron Oud is the head of Neuromuscular Disease Research Group at Folkhälsan Research Center of the Temple Neuromuscular Center, Finland, a highly specialized center for comprehensive care and research of all types of genetic and acquired conditions of muscle, nerve, neuromuscular junction. Professor Oud received the German Duchenne Erb Pre-Science Award by the German Muscular Dystrophy Association, Deutsch, for his leading efforts in the neuromuscular disease zone. Welcome, dear Professor.
Thank you very much
for
the introduction, and thank you for the invitation, especially Professor Nadia for this and all the others in the organizing committee. And I must say it's good to be here back again after the pandemic interval of a few years. So I will concentrate on the limb girdles for this talk, although it covers sort of neuromuscular disorders at large, but mostly muscular dystrophies. So the problem is that the next slide will not show up. I will try directly on the computer. No, okay. The problem we face in our neuromuscular clinics is that we have to deal with more than 1,000 different reported types of diseases. So how to get the final solution in your patient you have visiting? And by just looking, hearing the history and doing the clinical examination, it is usually not possible to make a final diagnosis. However, there are a few exceptions. So in the advanced stage of myotonic dystrophy type 2, the experienced clinician can directly expect the diagnosis. The same is with Duchenne-Becker typical cases with extreme calf hypertrophy. FSHD, the same thing if it's the typical form, but FSHD can be very variable. So you miss some of the most typical findings in many patients. If you have a girl with the Duchenne phenotype, proximal weakness and calf hypertrophy, it is usually alpha-sarcoglycanopathy. We have the late onset oculopharyngeal muscular dystrophy. Also in the typical case, you are able to suspect directly. In the other neuromuscular diseases, we have the advanced ALS, of course, the Kennedy's disease, spinal and bulbar muscular atrophy. If you have the perioral twitches when the patient starts talking, combined with the other phenotypes, you have the diagnosis almost directly, also by clinical seeing. The HNPP syndrome, typical, yes. Congenital myotonia, the same thing. And periodic paralysis just by listening to the anamnestic features. And also, I would say, typical cases of SMA1 and 2, if you have all signs, including the tongue fasciculations, you can suspect directly the diagnosis and go for the corresponding genetic testing. But if you have a limb-girdle phenotype, is it myogenic? Is it neurogenic? Is it a form of inflammatory myositis? Or is it even a transmission problem, a myasthenic issue? We have different forms of myogenic mechanisms. We have the dystrophies, we have the group of limb girdles, as we can see. We have the Becker form, usually, although the large calf hypertrophy will direct you. But as indicated in the previous talks, we have female carriers of Duchenne mutations that can have skewed X inactivation. And if that is making the defect allele more prevalently expressed in the muscle, the female carrier will have a manifestation of muscle disease. It's not frequent. To some extent, it is present in maybe 5% of the female carriers, but non-significant, non-clinical, no clinical symptoms. But in 1% around, we have a manifestation of progressive muscle disease, and it will show up like a limb girdle. So very important to, especially in families where you don't have any Duchenne males or Becker males. The single female case presenting, and it can take a long time until you find the diagnosis of a manifesting DMD carrier. And we have several other myopathies that show a limb girdle phenotype, of course. I would point out the neurogenic forms. Normally, they will be sorted out by your neurophysiological studies and the EMG, but sometimes not directly. So we now have, when we are have these large European collaborations, work on different forms of limb girdles, it has turned out that several patients have been referred as limb girdle muscular dystrophies for genetic studies, and in fact turned out to be SMA3 and SMA4 cases. And as you know, combined deletion in exon 7 with increased number of SMN2 copies caused that. We have a specific form of adult onset SMA, very prevalent in Finland as the Jokela type, SMA-J in OMIM, also presenting with the limb girdle phenotype, but usually then taking out as with Kennedy disease directly by EMG. Myositis, yes. Of course, normally the myositis presents with rather rapidly progressive muscle weakness, and you directly suspect it if the weakness has developed over the last few weeks. But there are also other possibilities, and we will have a look at some of them. Myasthenias very rarely are confused with limb girdle muscular dystrophy, but of course we have the Lambert-Eaton syndrome, and we have some of the congenital myasthenias like DOC7, where the normally existing ptosis is not that obvious, and limb girdle weakness is the more sort of presenting finding. After you have made your examination, you normally refer the patient to further studies like CK, EMG, biopsy, muscle MRI, and or NGS sequencing. And this is the new thing now. Normally, or many clinicians prefer to go very directly into NGS sequencing, and we will see what impact that has on the practical performance. I will just highlight the interest of muscle imaging. It is still not widely used as a first-line diagnostic method after your clinical examination, but it should be actually because the information you get from muscle imaging, MRI preferentially, is so huge. And helps you not only with the primary diagnostics, but also with the secondary, when you have made your genetic NGS sequencing and come up with a few probable likely variants. You then have to go back to the patient and see which variant fits the phenotype, and here you have help of the muscle MRI. So we have the next generation sequencing, which are powerful new tools. Does it make life easier for us? Yes, to some extent, but also more complicated, as we will see. We have an expanding number of new disease entities, which we need to update ourselves on every year. And to exemplify that, 30 years ago, recessive limb girdle muscular dystrophy was one disease. Now we have not only 24, but we have 27 actually recognized, and even more incoming. The same with distal myopathies, which are actually dystrophies, even if they are called myopathies. 30 years ago, there were 5 entities. Now we have even more than 30 of them. So here just a list of the currently listed recessive limb girdles in OMIM up to 27, and there are more incoming. Of course, not all are equally frequent in all countries. I just highlight the ones we see in Finland, but the situation in Egypt is totally different. You have a high degree of cousin marriages, which makes, of course, any local founder mutation very important, and will change the sort of distribution of which of these categories are more prevalent than others. The same with the distal myopathies. Some are quite rare, but some are, the ones in red here I have listed, they are sort of frequently seen in different populations, so you should have them also in Egypt. Previously we used algorithms to try to get the final or suspect gene to test by Sanger sequencing, and we used then, of course, the different clinical variabilities, but also muscle imaging to get the deep phenotyping and a shorter list of possible variants, like here in distal myopathies. But still, the number of possible genes is too high, and you can't start Sanger sequencing them all. So, of course, NGS techniques have helped us a lot here. But you can still use these algorithms after you have the genetic results to see which of the genes are more likely than others. So we have the motor neuron diseases with limb girdle phenotype, which I already indicated we need to think of. So SMA3 and SMA4, where we also need the SMN2 copy number besides the deletion of exon 7 with the MLPA test. Kennedy's disease, yes, as indicated, but it needs the specific mutation assessment. It does not come up with NGS techniques. The Jokela type of SMA has also its own difficulties because the EMG can be both myogenic and neurogenic, and you are confused. And the same will muscle imaging may look a bit dystrophic to some extent, like here in the calf muscles. So there are places for confusions. The limb girdle myasthenic phenotypes with Lambert-Eaton, you know, is caused by voltage-gated calcium channel antibodies, and titers are, of course, easy to check if you have the suspicion. But when do you have the suspicion? You have the suspicion of a myasthenic problem if there is no family and your MRI is totally normal, CK is totally normal, despite clear limb girdle weakness. So here again, MRI is very important. You can't have that data by sort of other methods. And if that is the situation, you need to think of Lambert-Eaton. And in children with childhood onset limb girdle phenotypes, I indicated there are some of the gene forms of myasthenic syndromes that may also be confusing and have the heavy limb girdle weakness. So just to show you which of the components in the transmission are involved. For Lambert-Eaton, you have a problem with the calcium channel on the synaptic presynaptic membrane, and you have a problem with release of acetylcholine into the synapse. And others are all on the postsynaptic membrane, causing difficulties with accepting the acetylcholine and making the correct potential change on the membrane. So, how to solve the final diagnosis? It was a long process previously. You had to go through all these stages with additional auxiliary testing methods. And if you have a specific disease in suspicion, then you can also use protein studies, Western blotting, and immunohistochemistry to check if your gene of interest could be the possibility, and if the protein studies show abnormality, then you can go for gene testing and other genetic approaches. However, this was a tedious process and did not always provide the result. I will give one example of a patient with a progressive limb-girdle phenotype from age 50, was examined long time ago, had very high CKs and fiber necrosis, and was diagnosed with polymyositis at the time. And then after 11 years, the rheumatologist consulting, because there was no good therapy response, of course, too long delay, but still I asked for the muscle MRI, and this clearly shows this is no myositis at all. It is muscular dystrophy, and just based on the findings here, with the asymmetry on the lower legs, the heavy posterior involvement on the thighs, gave me the direct suspicion, which then proved to be correct. So now the main genetic technique is the exome sequencing, widely used. The usual problem is too many unique or very rare variants in all of us. Assessment of pathogenicity is very difficult because the predictive tools we can use, algorithms, are not valid for big muscle genes. And now we need experience from geneticists, clinicians, methods to test the significance. Family studies for segregation, RNA or cDNA transcript assessment, protein studies, so a multidisciplinary teamwork. Many variants are also incorrectly reported as pathogenic, which of course confuses the geneticists. Exome sequencing, still not whole exome, even if it's called whole exome, there is no full coverage of all gene parts of interest, but it gets cheaper all the time. And the success rate in previously untested limb-girdle phenotypes is about 30 to 35%. Another variant of this is the targeted exome sequencing. So we have a capture of known disease genes in gene panels, and we use this as the first line. At our center, we have one gene panel for all myopathy genes, and one gene panel for neuropathy, motor neuron, HSP, and CMS genes. So instead of 20,000 genes, we are sequencing about 350 genes per panel, and we have almost 100% coverage, which is good. But you need to update these panels annually. It is also cheaper than exome sequencing, including full bioinformatics analysis. Limitations, as with exome sequencing, there is no detection of repeat expansions, and previously unknown genes cannot be assessed. I will show you the complexity by taking the example of the titinopathies. Titin is the biggest gene in nature, So before NGS, we had only identified very few disease types by linkage in families and Sanger sequencing, and now with the new technique, the list of different forms of tendinopathy is just expanding. And we still do not know what recessive missense variants may do in most cases. Because the gene is so big, it could not be sequenced by Sanger sequencing, but the new technique makes it possible. So I already indicated complex mutations are not covered by exome sequencing, so you still need the specific mutation assessments. Now how you proceed has now changed. So many clinicians go directly if they have a suspicion of a limb-girdle muscular dystrophy. So after the clinical examination, they may go directly for exome sequencing or gene panels, or have different other examinations in between. I would prefer to clearly do neurophysiology, CK, and MRI, and then decide whether also to need muscle biopsy before exome sequencing, but there is different ways to do it. So how to interpret the findings in your gene panels or exome sequencing? We are doing so that after the in-house bioinformatics pipeline, you end up usually with 10 to 30 rare or novel variants of interest. These are then checked by the molecular geneticist and make a shorter list of potential interesting variants. And this is now then discussed with the clinicians, this list of potential variants, and compared with the clinical phenotype. Which of these variants may fit the phenotype and which not. So we have 4 types of different outcomes after this procedure. The easy result is if we have a known mutation in a disease-compatible gene. And if you have a read depth of that variant in your exome sequencing about 30 times, then you don't need to Sanger sequence to verify. A good result if you have a new mutation in a gene compatible with the disease phenotype of your patient. But this needs more studies, so we need a segregation study in the family to see how that variant is doing in healthy and possibly other affected individuals. And we may need also protein or transcript molecular pathology studies of the muscle biopsy to show the pathogenic effect of the variant. We have a third category of an interesting result. We have a new unique mutation, but the phenotype is not directly compatible with what is previously known with the gene. And this needs a lot of more work to exclude or confirm that to be the cause of the disease. And we of course have the fourth category, nothing of interest at all. If the new panel is negative and the disease is clearly genetic, of course there is a major interest to also chase a previously unknown gene. And that is of course part of also research efforts. So we can use genome sequencing, which has a lot more to tell than exome sequencing. And it's still a bit complicated for routine diagnostics. And you have also to bear in mind, even if it's called whole genome sequencing, all genome regions are not fully covered still. And the bioinformatics processing needs a lot of capacity compared to exome sequencing. So you can redo exome sequencing with different platforms and preferentially using trio samples to have a better way to assess the possible harmful variants. And then you can use RNA sequencing to sequence the transcripts, the whole transcriptome. This is underway to be used in clinical diagnostics, but it is far from easy. It is, though, important for the assessment of deep intronic splicing mutations that usually are not understood to cause splicing. Just to show the extreme complexity we can face. This is not normal problems, but extreme problems we can have. Family with a child born 2015 with severe hypotonia and arthrogryposis at birth. And this is her MRIs, and you can see there is no muscle at all in the calves. On the thighs, largely nothing at all, just remnants in rectus femoris, adductor longus, and sartorius. On the hip level, no gluteal muscles at all. And of course, this explains the arthrogryposis. If you have no muscle at all on one side on the limb and just on the other side, then the hand or the feet will be turned in deviation. CK normal, non-progressive evolution, and her mother also had the congenital myopathy. She had delayed motor milestones, but no severe hypotonia and no arthrogryposis. But later, mildly progressive proximal weakness with high CK levels. And you can see her MRIs are totally different. So in the daughter, in the child, these white areas, the muscles were never developed, and that we call amyoplasia. Amyoplasia, no muscles were developed. And we know that. We have learned that during the last years. We know that that can exist in certain forms of biallelic titinopathies. So we already, by looking at the phenotype, we knew about what to sort of go for. However, this specific form of amyoplasia, now it won't go back for me. Yeah. This specific form of amyoplasia we know of in biallelic truncating titin mutations, but it needs, one of those needs to, or both needs to be located in a certain region of the gene, 40 exon region called meta-only exon. Why it's called that way? Because these exons are not expressed in adult life after birth in the muscle, but they are very important in fetal development. So in combination with other truncations, this is the cause of amyoplasia. So the gene panel variants in the daughter showed, as expected, one truncating variant, but not the second one at all. And these were first checked in the mother. She had only the missense, which did not explain. Okay, I'm late, I'm over time, apparently. Sorry. I will not take many minutes more. 5 minutes for sure. I didn't pay attention to there was a clock, but sorry. You can add more than 1 minute? No. Okay, okay. We will have to fix this. So we did protein studies and we checked the exome in the mother and found a nonsense variant in the correct location in the meta exons, but still this finding in the mother, this explained the mother's phenotype, but not the one in the daughter. So we had to go further, and this was a very tedious program. We checked on RNA sequencing, what the splicing variant in the mother could do. Yes, we have different forms of transcripts, and still we did not have the explanation for the daughter until my brilliant titanium specialist in my lab went through all the raw data once again and found that meta-only exon variant in the daughter to explain the phenotype. It was not identified. It was first directly filtered out because of the imbalanced allele expression we have with these meta-only exons. So just to tell you how complex the things can be and what capacities you need in your neuromuscular center to be able to clarify the final diagnosis. I think I will end there. Thank you.
Thank you very much, Professor Wood. It's obvious that we already know a lot of information about muscle disease, but it seems that we are still waiting for much more things to know. Thank you very much, Professor Wood, and we will postpone the questions after the second speaker.
السلام عليكم ورحمة الله وبركاته. ما ينفعش نكون موجودين طبعا من غير ما نقدم الشكر والتحية للأستاذة الدكتورة ناجية فهمي، جعلها الله في ميزان حسناتها. ودي طبعا دعوة لكل الشباب الموجودين ما شاء الله الحضور، يعني يحذو حذو دكتورة ناجية وفرصة، يعني شوف دكتورة ناجية كنا فين وبقينا فين، ففرصة يعني عظيمة كده تاخدوها قدوة حسنة. انتوا هي فرشت الأرض، والأرض أعتقد دلوقتي مفروشة بالورود. يعني اللي كنا نقول لو بطلنا نحلم نموت، لا ما بقتش حلم، بقت حقيقة. فدعوة لكل الموجودين الصغيرين كده يبدأوا ياخدوا الموضوع، وإن شاء الله الموضوع بقى حقيقة. ما ينفعش أكون موجود برضه هنا على المنصة من غير أكون سعيد بتواجدي مع أستاذي القدير أستاذ الدكتور أسامة عبد الغني، أختي العزيزة دكتور إيمان المراكبي، الأخ العزيز دكتور محمد حمدي. It's happy to me to introduce Professor Ludolp. Professor Ludolp from Ulm. I am happy to visit Ulm because my daughter study engineering in Ulm. Professor Albert Ludolp, Professor and chairperson of Department of Neurology, University of Ulm. Happy to see you many times in Egypt and outside in Egypt. Very nice to me to introduce Professor Ludolp. Welcome in Egypt.
Thank you very much for your kind words, and I'm very grateful to be here again. We had a gap, you mentioned it as well, but I tell you, our cooperation went on and we had a lot of success, even with viruses. I was asked to talk about the approach to the diagnosis of ALS, and I have organized my talk in a traditional way. The basis of course, neurology is neuroanatomy and neuropathology, and there are news in this regard in ALS. And then I talk about approach to the diagnosis, and then I will discuss the supporting evidence that we have to the diagnosis, diagnostic criteria, biomarker, and of course also electrophysiology. So let us talk about first on neuroanatomy. It's a traditional way to approach neurology. You know that Charcot revolutionized the neurologists and by his clinical anatomical method, but about 30 or 40 years ago, this man, Heiko Braak, thought that only autopsies should not be done in neurological diseases. We should more concentrate on a longitudinal view of these diseases to prevent the diseases. And the champion of this was, as you know, Heiko Braak, and he staged Alzheimer's and Parkinson's disease in a longitudinal fashion. And of course, this got results, and perhaps you remember that in a journalistic way, he found that Parkinson's started in the stomach. So it was useful, and he started to work on this, on ALS, and he used a molecular marker, not tau, not synuclein. He used p-TDP43, a marker which was discovered by Manuela Neumann, now in Tübingen, in 2006. And what did he find? Not surprisingly, ALS started off in the motor cortex and then went along the association fibers into the gyrus rectus, further into the orbitofrontal cortex, and very late in the hippocampus. But this is not the only thing. This is the spreading around the association fibers, which you see here. But whenever this process affected neural populations which are connected monosynaptically with subcortical nuclei, like the alpha motor neurons, then these subcortical nuclei are also affected by the disease. So this is of course descriptive. The mechanistic view is not fully explored, but here are some thoughts. As you see here, there are nuclei in the nervous system which are heavily affected by TDP43 pathology, like the hypoglossal nucleus, as shown here. The neighboring dorsal vagal nucleus, just 1 or 2 millimeters away, is not affected at all. So we think, of course, that cell-to-cell transfection between contiguous cells is very unlikely. So in a picture, a neighboring house is not affected by the fire of the neighbor. Rather, there is TDP40 pathology present over huge anatomical distances. And these distances are closely connected by axonal pathways. And therefore we think that the connectome, the human connectome, is the deciding factor in spreading, and secondarily, of course, one thinks about axonal transport. So to repeat this, vulnerable subcortical neurons show strong and direct monosynaptic cortical input. They are all glutamatergic, and if you again want to say it in a journalistic fashion, there might be an all good things come from above principle. So in other words, ALS is not a primary muscle disease, it's a primary cortical disease. And in the brain, neurons without direct cortical input are largely spared, like the locus ceruleus. This is important for our approach to diagnosis. And therefore, I want to emphasize this. But let me first start with the traditional view of ALS. We all know it's a progressive disease. It's clinically mostly motor, with upper and lower motor neuron deficits, brisk reflexes, amyotrophy. It starts focal. It spreads continuously. I will go deeper into it because it reflects Braak's views. And it's finally generalized. Progresses over 2 to 4 years. The patient is de-efferentiated. He cannot speak. He cannot write. He cannot show by posture what he is thinking. De-efferentiated. He dies by, or she dies by, respiratory insufficiency, and the incidence in our country is 3.1 per 100,000, which translates into a lifetime risk of more than 1 to 400. This first description that I found in Germany before Charcot adds additional symptoms which we all know: incomplete paresis, focal onset. It was strange to observe that the skin of the leg showed tremendous switches, fasciculations of course, and it also adds, or does not add, the man did not live long, the paresis got complete, and he died after a few months emaciated. It was always a little bit overlooked. The patients get catabolic during the course of the disease. We have several kinds of focal onsets. This is a typical patient with a pseudobulbar or bulbar variant, meaning he has deficits of swallowing and speech. He has a tongue paresis, he cannot move his tongue anymore. And from this subform, women are more affected than men, and I believe it always generalizes into ALS. In more than 40 years of neurological practice, I've never seen a patient who did not generalize. It's a negative prognostic factor. So, if we look at the distribution of the focal onset forms in our register, this comprises 1,900 patients when we counted it. A third bulbar onset, a third arms, a third legs. I would like to show you in more detail the thoracic onset form, because it is often overlooked, also in our country. This is a typical patient, 56-year-old, increasing dyspnea, 20 kilo weight loss, catabolic, only progressive for 6 months, extensive examinations by pulmonology, by cardiology, nothing found. Then he got a specific walking problem. He had a bent posture, which was due to weakness of erector spinae, and he was sent to us because they wanted to have it, to get him a tracheostoma. So now I hope this works. Yeah, of course, this is, he does not talk in German. He just, you see it, he recognized that during swimming, he got dyspneic. And when he came into our department, he immediately supplied him with non-invasive ventilation, because we saw that capnometry showed a CO2 of 80, double the normal amount. And then he got the mask and he was immediately fine. Immediately. High pressure ventilation helps in these patients immediately. They see it as a drug, working as a drug. He immediately fell asleep, which he couldn't do for 3 or 4 months. It was like the effect of a medication. For that reason, you have to know this subtype, because you can help these patients immediately. First, measure CO2, know, of course, the subtype, and then you can help him. This is a variant of ALS which is often overlooked. My colleague Katharina Kandler just summarized our experience. We had 150 patients, 2 to 3%. The problem, 2 to 3% of all patients. Diagnostically, they often use non-neurological pathways, cardiology, pulmonology, nothing is found. Helpless colleagues do an intubation. There are 2 subforms which finally get together. Primarily is the actor spinae affected in about 40%, or primarily is the diaphragma in 60%, and they benefit enormously from non-invasive ventilation. The life expectancy is increased by 3 to 5 years in our experience. And don't forget, this is also symptomatic treatment. They can sleep, They are not less exhausted, and they do not have the typical morning headache. So the second rule, which is based a little bit on Braque's results of neuropathology, has been reported first by John Ravitz and Albert Laspada, before Braque, 2 or 3 years before. They discussed something which was known to every ALS person, but which was not readily explained. If the disease starts, for example, like in this man, at the arm, then it spreads continuously over the body. In this man, to the right leg. But then the continuous way that the disease spreads does not go to the left leg, it spreads continuously to the left arm. And this rule is true for about 90% of the patients. If it's not have doubts on your diagnosis, a rule with exceptions, and I will show you how I mean this. First, perhaps more details. In our patients, more than 100,000 patients, 1,000 patients we analyzed. 2/3 of the patients show primarily horizontal spreading, meaning from legs to leg or arm to arm. 25% show vertical spreading, hemiplegic forms from leg to arm or arm to leg. But 25% of the bulbar patients do not spread to the arm, they spread to the leg directly, which is, of course, a seemingly exception to the rule. But if you consider Braque, it's cortical spreading, it's not. It's just a proof that this is, or a better argument that this is cortical spreading. Another rule which is based on neuroanatomy and neuropathology is that we know that, like in muscle diseases, like Bjarne Ud always emphasizes, there are specific muscles which are involved, a pattern recognition. In this disease, if someone starts with foot drop on the left side, then it's likely 70%, as I told you, that he develops foot drop on the right side. The next muscle is not the gastrocnemius, it's not the quadriceps, no, it's the biceps femoris. And why is this so? If you remember, Braque postulated that only monosynaptically connected muscles, or I need another wording, that the monosynaptically connected muscles are wasted at first. And therefore, we decided to look at about 1,000 patients and look at the pattern of paresis in ALS. And we saw that the biceps femoris is always more affected than triceps. Hand extensors more than flexors. The intrinsic hand muscles more than the triceps. The biceps femoris more than quadriceps, and foot extensors more than the flexors. This is known to many clinicians, but it is not known that this exactly represents monosynaptic innervations of anterior horn cells from bed cells from the cortex. It's a monosynaptic pattern, and it's an architecture of the corticospinal tract which is unique to humans. Only higher primates like chimpanzees or orang-utans or macaques have the same pattern of innervation, which means, which I put in red, that ALS is a disease specific to humans, which has major implications, which I cannot discuss this. Now I want to discuss the ALS variants. This is a 58-year-old patient. The prior diagnosis before sent to us, multifocal motor neuropathies. She got immunoglobulins. She was sick for 4 years, and she had a flaccid paresis of the arms. The diagnosis was multifocal motor neuropathies, got immunoglobulins, no response, 10 times. We looked at these patients and compared them with normal ALS patients, and as you see here, the sex distribution is different as in ALS, more men. The survival of these patients is much longer, double than normal ALS patients, and the decline of the ALS FRS score is smaller, so it's not as aggressive. And the age distribution is more in the older age ranges. We have many wrong diagnoses in Germany in this subform. The most frequent is multifocal motor neuropathy, but sometimes the diagnosis is carpal tunnel syndrome, spinal muscular atrophy, and so on. So it's often misdiagnosed, and the life expectancy, this is flail arm, this is ALS, is much better than ALS. So why is it remarkable? By the way, in France and Germany, it's not called flail arm syndrome, it's called Vulpian-Bernard syndrome. Asymmetric proximal paralysis of the arms, later complete paraparesis. Then they develop central signs at the legs and later bulbar deficits. Their life expectancy is about 10 years, male-female ratio, different from ALS. It's not multifocal motor neuropathy. You don't have to administer immunoglobulins, and you better think of the late alveolar hypoventilation and treat them. This is a patient with primary lateral sclerosis, 50-year-old patient. He developed a gait disorder of the right leg, psychogenic. It was called, but then the skilled movements of the right hand were also involved. The diagnosis was progressive stroke, print, perhaps you know that. And after 6 years, of course, he got central tetraparesis. This is typical primary lateral sclerosis, and you see him walking. Perhaps you saw that he has a rigidity, and this is walking after L-DOPA. They sometimes respond L-DOPA and like it. The prognosis is much better than ALS. The same is true for progressive muscular atrophy, which is only distinguishable from ALS by the somewhat better, by the absent reflexes. Otherwise, with regard to neuropathology and neuroradiology, they are not distinguishable. There are cortical spinal tract involvement whenever you examine such a patient without increased reflexes. It's a subform of ALS. So these are the variants with a better prognosis. Flail arm, I told you. Flail leg, I didn't discuss, it's similar. Primary lateral sclerosis and progressive muscular atrophy. Again, I repeat it, there is neuroradiological and neuroanatomical evidence that these variants do not differ from ALS in principle. So I will now discuss the supporting evidence. Of course, you know all these pictures of the SMA miracle, a young child with a tetraparesis, which could not move, floppy infant, which moved much better after 6 months only. And this, of course, this child is not normal, by the way, on the right side, but it's a miracle, and we always want to pursue that. We want to pursue that by newborn screening, by early diagnosis. We heard about early diagnosis quite often this morning, and therefore the diagnostic criteria are changing. This was already thought of in 2015 by the World Federation of Neurology Group, which I chaired at that time, and we developed the 1+1 rule. It was further developed by the Gold Coast criteria, which mirror these suggestions from 2015. And what does 1+1 mean? It first means we need earlier diagnosis. Secondly, how do we do this? We only need progressive weakness of at least one region, an arm or a leg or bulbar. But we need upper and lower motor neuron signs, 1 plus 1 in one region, or if there are only lower or upper motor neuron signs, then we need a second motor neuron sign in an additional limb. Of course, we have to do modern differential diagnosis, which we always do in ALS if we are responsible physicians. Of course, we have to exclude polyradicular lesions. That's the normal practice. These Gold Coast criteria have been shown to have high sensitivity, 92%, no miracle. They must be sensitive. The problem is, of course, specificity, and that is worked out during the present time. This is the only gap. We use them in our clinic. So let me turn to biomarkers. This is a biomarker curve of the infant that you saw, NFL and NFH in the CSF. You see after administration of, oh, it's very hard to move. I try to show it to you. After administration of nusinersen, these levels went down like in a black and white picture. It's clearly showing the effect of the treatment. We have this also in ALS. We do these axonal biomarkers. Axonal, it is mirroring Braque's ideas, axonal disease of corticoafferent fibers. These axonal markers are predictive in CSF. If they are high, patient dies early. If they are low, they die late. And if it has been shown for 4 or 5 compounds, they show efficacy of a compound. This is not, let's say, set into stone, but the experience that we have in the last 3 or 4 years that they predict therapeutics. The same is true in serum. However, the serum biomarkers are not surprisingly, as sensitive as the CSF markers. But it's the same true. The same is true. NFL correlates with disease duration, progression rate, survival. So you didn't hear anything about electrophysiology. This is normally a major part of a talk which addresses the diagnosis of ALS. Some people say, you know, you gave an interesting talk, but do we need neurophysiology at all? And my answer is, of course, yes, because the patient with ALS dies not of Braque stages or frontal disease. No, it dies of anterior horn cell disease. And therefore, it's a major prognostic factor and an important biomarker. But we know now that ALS affects specific muscles. Why do you, I'm also an electrophysiologist, why does one examine the triceps or the gastrocnemius? It is not useful. You should, I think one should change the protocols of examinations and, for example, look at the tibial anterior or the head extensors rather than the flexors. So EMG is absolutely requested, is as important as, or the most important supporting method. Of course, neurofilaments follow at the present time, but it is still, of course, necessary. So what I did I want to tell you? First, the sentence which is notorious, clinical neurology is still based on neuroanatomy. We know since 1870 that that ALS is a predominant progressive disease of motor neurons. But we learned that also clinical features of ALS are progressive spreading and a monosynaptic pattern of muscle paresis. And therefore we can simplify our clinical approach to the disease. Pattern recognition, like in muscle disease, we can develop new, simpler diagnostic criteria, and I can add that biomarkers play an increasing role in the diagnosis, and of course, electrophysiology is also part of the diagnosis, but I think it should be a little bit modified. Thank you.
Thanks a lot, Professor Rudolph, for the very nice presentation and very nice remarks about the basics of understanding in neurology as a whole, not only in ALS. دكتور محمد حمدي هيفتح المناقشة.
Well, unfortunately we reached the end, so we have to thank you, Professor Albert and Professor Oud, for this fruitful presentation, and it's time for discussion. So questions, please. Any questions? Okay.
Professor Ludolf, I'd like to ask you about your opinion in cases where the genetic testing is not in line with the clinical phenotypes or in the clinical diagnosis. If a patient is clinically not ALS, but his genetic testing comes very suggestive of ALS, or vice versa.
You know, the answer I skipped during my talk. You immediately saw again. In our suggestions in 2015, we added to the 1+1 rule paresis of a limb plus a genetic mutation. The Gold Coast criteria do not include it. And the reason is what Bjarne Oud just mentioned, because many mutations, this is true also for ALS, we do not know whether they are pathogenic or not. And therefore, the Gold Coast criteria authors left this out, this problematic field. We were a little bit more innocent in 2015, but we learned. So I think the Gold Coast people are right, but in the real world, of course, I'm pragmatic as a physician. If I clearly know this is a mutation which is always pathogenic, and of course, this is not true, but black and white is always not true. But then I'm very suspicious of ALS by having only a slight paresis of a hand.
Well,
I would just like to add that this is not only for ALS, but the whole neuromuscular field. The final diagnosis is extremely important. And now, with this new problem of having a number of variants of unknown significance, the patient may be even more stressed to have that list and no final confirmation what is what. So we definitely need to improve our services, as I indicated, with the multidisciplinary competencies in fields needed for getting to the final diagnosis. It is important for the patient, for the family, for the genetic counseling. What is my prognosis? Will I die of this disease? All that is open as long as we don't have the final diagnosis.
You know, I mean, the problem in the practice is that, therefore I added the word pragmatic. If we have a clearly dominant disease in a family, we have these families for following 5 generations. And then we have now these antisense oligonucleotides against SOD. And we have a study in which these patients can have preventive therapy. And if they have small deficits at the end, we use the 1+1 rule.
Okay.
Well, I do have a question. First of all, I'm quite happy to see both eminent professors from Germany. I spent part of my fellowship program in Germany, Essen University Hospital, so I know how advanced Germany in the field of medicine. I do have a question as regarding the role of the MRI muscles It seems that is controversial. In the case of primary muscle dystrophy, it solves a riddle or a problem like the case you have mentioned about the polymyositis. But how about the role of the MRI muscles for the ALS? How superior
You know,
it is?
we plagiarized you doing a whole body MRI and looking at the pattern of the parases that are emphasized. We did not publish this yet, but you even can see this in the MRI. This monosynaptic pattern of parases. And this algorithm will be part of the future of diagnosis. Which part, 10%, 20%, I don't know yet.
So, as I indicated, as soon as you order additional studies in a neuromuscular patients to find a diagnosis after your clinical examination, so you order normally CK and neurophysiology, you should also order muscle MRI. And over time you get acquainted to read those results yourself because it varies in different countries. In many countries, radiologists are currently not used to read muscle MRIs and to know what is important. So I have urged the clinicians to learn it themselves and then of course take also the report of the radiologist, but to know how to interpret the data themselves.
We also did what you suggested here because we developed an algorithm, neurologists, which quantify muscle mass of the respective muscles, and then you immediately see. We will publish this year. Still.
Very
Professor
important.
Rodolphe. Thank you, Professor Rodolphe. Thank you very much. In the future, there is hope for, in the pipeline, a new trend for ALS?
Sorry?
There is new treatment in the future or pipeline in treatment of ALS?
Oh, I will focus on treatment tomorrow.
Tomorrow.
So there are many drugs which are on the way. Which are on the way, but you have to talk about everything because it is a very detailed procedure. It's not a black and white picture.
And Sarepta has also projects ongoing for 4 different limb girdles, so mostly gene transfers.
Okay, I have one last question because we are already out of time. For Professor Albert Loldov, I want to ask you about a patient that I saw recently in our department at Ain Shams University. She was presented with flail arms, but it was rather symmetrical and subtle changes, subtle weakness in the lower limbs. And we had a problem in the diagnosis, so I'd like to know your differential diagnosis.
Yeah, it's always in the beginning, like always in ALS, asymmetric. And in the literature, you find that it's mostly proximal asymmetric. This is true, but the third is distally asymmetric. And secondarily, after the onset at the limbs without reflex, at the upper limbs without reflex, then it affects the legs. In my view, mostly with predominant upper motor neuron sites. So
yes.
I think your patient roughly fits.
Okay, thank you very much. Thank you very much, dear professors, and Professor Osama will close this session. And I want to thank Professor Nagia for this wonderful event, the 3rd International Conference for Advances in Neuromuscular Disorders. Professor Nagia is a leader in this field, and we all learn from her.
Thank you very much. I think we are running short of time. May I invite the next chairpersons for the next session, Professor Dr. Marian Yusri, Professor Dr. Nagia Fahmi, Professor Dr. إيمان سيف. يمكن دي الجلسة الوحيدة اللي فيها 3 males على فكرة و 1 female. كل الجلسات معظم الجلسات are female predominant. Okay. Good luck.
we are out of time, but I have announcement because this is an SMA session. Novartis company and Ministry of Health, they have a small booklet. They print it in a very nice way. Stepwise is the diagnosis of SMA. Just to help us, what is SMA? The very early diagnosis, the differential diagnosis. So after the session, they will distribute this booklet to you.
طبعا أنا سعيدة جدا بوجودي بين أساتذتي وزملائي وزميلاتي في طب عين شمس، وطبعا بشكر الأستاذة الدكتورة ناجية فهمي. هي طبعا طبيبة بدرجة عالمة جليلة، حطت هدف قدامها والحقيقة وصلت له من يعني أصعب الطرق، مش هنقول أسهل الطرق، وهي طبعا أكيد مثل يحتذى به لكل الأجيال الصغيرة والكبيرة، ونتمنى لها طبعا كل خير في التخصص الجميل بتاعها ده. الحقيقة هي أسعدت العيانين قبل الدكاترة وعلمتنا كلنا إنه كل واحد فينا عنده هدف لابد إن شاء الله يوصل له، وطبعا بنشكرها ودايما متألقة ودايما في نجاح وتألق دائم إن شاء الله. دلوقتي أنا بقدم أستاذة الدكتورة مريان يسري، Clinical Approach of Spinal Muscular Atrophy, Cairo University.
Thank you very much, dear professors, chairs. It gives me great pleasure to be in this very elite conference, and I would like to thank very much Professor Dr. Nagia for her invitation. I'm going to talk today about the clinical approach to spinal muscle atrophy, which is the hot topic, of course, these days. What is spinal muscle atrophy? The spinal muscle atrophies comprise a group of disorders characterized by progressive weakness of lower motor neurons. SMA is the second most common autosomal recessive inherited disorders in humans after cystic fibrosis, and it is often called the #1 genetic killer of children under the age of 2, of course, before the treatment. Etiology and genetic background: in 95% of cases, it is caused by a defect in SMN1 gene or survival motor neuron 1 gene that encode for SMN protein. SMN protein is especially abundant in the motor neurons of the spinal cord. A majority of patients has homozygous deletion in exon 7 and 8 of the SMN1 gene or deletion of exon 7 only. Most patients inherit SMN1 deletion from their parents in an autosomal recessive pattern. This is the primary gene, which is the SMN1 gene, and this is SMN2 gene, which is the backup gene. Most of the SMN proteins comes from SMN1 gene, and SMN2 gene has just some abnormality in the form of cytosine is replaced by with thymine nucleotide. So during pre-messenger RNA transcription, exon 7 is spliced from SMN2 gene. That's why SMN2 gene provides only for 10% of SMN proteins. That's why when SMN2 copies increases, the SMA severity decreases. The pathology, SMN protein, which is the byproduct of SMN1 gene, is very important in the integrity of the motor neurons. And as the age increases, more motor neurons are getting lost. Time is neurons for infants with SMA type 1. In SMA type 1, 95% of the motor neurons are lost by the age of 6 months, and as the age increases, more complications happens in the form of more nutritional support is required, more ventilatory support is required, and the condition deteriorates. So early diagnosis and treatment is critical to modulate the rapid and progressive degeneration seen in SMA type 1. What about the clinical manifestations of type 1, which is Werning-Hoffman? There is lack of acquisition of motor milestones. There is hypotonia, normal intellect. These children have very good intellectual functions. The eye contact is perfect. They have bell-shaped chest and paradoxical breathing due to the weakness of the intercostal muscles. They have weak cry, feeding difficulties, and of course, the hallmark is tongue fasciculations. As time passes, bulbar dysfunctions starts to occur in the form of weak suckling, and the feeding is prolonged, and there is difficulty in swallowing. That leads to repeated aspiration pneumonias and more respiratory problems. We have two types of SMA type 1. Type 1A, which is sometimes referred as type 0, that usually present in the first week or prenatally. Type 1B develops symptoms from 1 week till 3 months of life, and type 1C symptomatize between 3 and 6 months of life. This video shows the clinical presentation of SMA type 1, and it is provided by Novartis. Can I raise the voice of the video, please? Notice, of course, the severe head lag of those infants when you do the traction test.
Learn to spot the warning signs. Floppy baby. Head movement can be particularly tough for a baby with SMA. Here, she's unable to lift up her head while lying on her belly. Does your baby seem floppy? When you pick up your child, does it feel like she will slip out of your hands? Can she lift up and hold her head during tummy time? Most babies can lift their heads briefly, turning them side to side within the first month of their lives. They can typically lean on their forearms or push up from their belly at 2 to 3 months of age. This baby is an infant, just a month or so old, but still has no ability to hold her head. Instead of moving their head side to side, a baby with SMA may follow you with her eyes, rather than respond to you by turning her head your direction, as this baby does, keeping her head only to her right, or whatever direction it has been placed.
As we said, they are very intellectuals, and they follow only with their eyes because of the severe weakness.
Learn to spot the warning signs. Breathing. Babies with SMA may experience rapid breathing. Their chest may also appear bell-shaped. Sometimes you'll notice a baby's belly predominantly moving, or in a seesaw-like motion, seemingly pulling down the chest. This may be especially noticeable when a baby is on her back, like here. How is your baby's breathing? Is it very fast? Do you notice her belly moving in a fast, repetitive motion? Does her chest collapse or retract in, making a seesaw motion with her belly?
This is the seesaw motion that we see because of the weakness of the intercostal and their dependence on the abdominal muscles in breathing.
Learn to spot the warning signs. No anti-gravity movement. It's hard for this baby to lift her arms and legs into the air when she's lying on her back. It seems like she can't lift them up at all. Doctors may refer to this as having no anti-gravity movement. Does your baby easily lift up her arms and legs? Can she get her hands to her mouth? Can she lift her arms from her shoulders, her legs up from her hips? Could she when she was younger, but no longer can? Does she seem to anchor her arms from the elbows, moving her lower arm, wrist, and fingers from this point? Swinging them around? Does she wiggle her toes without moving much more of her legs?
As we can see, there is no elevation at the shoulder level. Only the movements comes from the elbow.
Learn to spot the warning signs. Frog-like leg positioning. Unable to independently extend legs, and/or his or her legs often remain in a frog-like position. This baby is struggling to extend her legs out on her own. Rather, her legs remain resting in a frog-like position. Can your baby lengthen and stretch her legs independently? Does she lift her legs up from her hips, bending at the knees, kicking? Or is this how she often rests, maintaining a frog-like position with her legs? Do her toes seem to move the most, or seem to be the only thing wiggling on her legs?
Last video.
Learn to spot the warning signs. No squirming. This little one is very still, showing no signs of moving about or squirming. Compare her to her twin brother. How minimally she moves where he kicks, reaches, grabs, and brings his hands to his mouth. You may also see how babies with SMA wiggle their fingers and toes, yet their trunk doesn't move. There's little to no movement from these babies' head, shoulders, knees, hips, or waist. Does your baby wiggle or swing her arms from her elbows, with her arms otherwise anchored? Is your baby squirmy? Does she wiggle about, kicking and reaching, or remain mostly still at her core?
I hope by presenting these videos, the clinical picture of SMA has been now very obvious to you. The clinical presentation as a sum up, there is hypotonia, floppy baby, proximal symmetrical muscle weakness, frog leg posture, abdominal breathing, bulbar muscle weakness, tongue fasciculations and atrophy, failure to grow, areflexia and hypotonia, difficulty to attain major developmental milestones, and sometimes joint contractures if there is in utero hypotonia. This is the case scenario about a child called Farah. This is the clinical scenario that usually happens in SMA type 1. She is a second child, normal pregnancy and delivery, admitted at the age of 3 months for viral respiratory tract infections with recurring intubation. And on examination, she has social smiles, track swell, persistent head lag, inability to lift the legs off the bed, couldn't lift the arms at the shoulders but could lift her forearms and grasp, able to be extubated after 2 days. By 6 months, she was unable to feed well. Parents agreed to gastrostomy tube but did not want artificial airway. She received palliative care and unfortunately she died at the age of 10 months. What about type 2, which is the intermediate type? The intermediate type usually present between 6 and 18 months of age. They achieve the ability to sit without support. However, they have proximal weakness affecting the legs more than the arms with hypotonia and areflexia, and a very peculiar clinical feature, which is the fine tremors in their hands. Tongue fasciculations may be present, but not universal. Many of them are static with no obvious deterioration at a particular point. They might develop scoliosis and hip dislocation, subluxation, and dysplasias, and they develop progressive intercostal weakness resulting in restrictive lung disease. Type 2 is further subclassified into type 2A. Those children could sit, but they lose the ability to sit over time, and type 2B, which are the stationary, maintaining the ability to sit independently. This is a type 2 patient. As you see, she can stand with support and with braces. She can move and she can sit unsupported. Type 3, which is the mild type, the Kugelberg-Wallander disease, they usually present between 18 months and adulthood. These patients can stand and walk independently, but they have difficulty in climbing the stairs, walking or running with abnormal gait. Tendon reflexes are often preserved at the time of presentation. Progressive weakness can lead to loss of ambulation, and they usually are misdiagnosed as Duchenne muscle dystrophy because of the progressive muscle weakness that usually occur after those children attain the ability of walking. Type 3 is further subclassified into symptom onset before 3 years or type 3B symptom onset after the age of 3 years. And as I said, they are usually misdiagnosed with Duchenne muscle dystrophy because both have prominent calves, but of course the CPK is very, very highly elevated in Duchenne. This video is of a young girl, teenager, who has SMA type 3. Notice the severe weakness of the truncal muscles, and the ability to sit from lying position is very, very limited. Type 4, of course, we don't see type 4 in pediatrics, but the symptoms occur after 20 years of age. The mean age is 30 years, and it is slowly progressive with small proportion of patients losing ambulation within 20 years of symptoms. Deformities and respiratory problems are rare, and this is the least prevalent subtype. According to the distribution of SMN2 copies, as I said, that as the types increases, or as more we have, type 1 has the least SMN2 copies. In the red indicates that we have only 2 copy numbers in type 1. Type 2 indicates that most of the cases have 3 copy numbers, and some of them have 2 copy numbers of SMN2. And in type 3, most of them have 3 copy numbers, and proportion of them have 4 copy numbers. SMA is a spectrum disease. The functional status of individual, whether non-sitter, sitter, or walker, may be altered by new therapy. As we get the new therapy, SMA type 2, who are the sitters, can go from type 2 to type 3 and become walkers. And as the disease progresses, type 2, who are the sitters, can be non-sitters and they lose this ability and they go to type 1. So this is a functional spectrum, and the implementation of standards of care should be tailored to each individual according to his functional status, not according to the synonymous type 1 or 2 or 3. We have chromosome 5 long arm or SMA syndromes other than SMA. If we have EMG and nerve conduction, denoting that we have anterior horn cell and we don't have any deletion mutations even by sequencing on chromosome number 5, we can think of other disorders like these disorders: lethal congenital contracture syndrome, SMA with pontocerebellar hypoplasia, SMA with respiratory distress, which is the SMART one, X-linked infantile SMA, and early onset non-chromosome 5 SMA. What about the clinical approach? How to approach a child with hypotonia? To approach a child with hypotonia, either the cause of hypotonia can be central, I mean like chromosomal disorders like Prader-Willi, metabolic diseases, spinal cord injuries, hypoxic ischemic encephalopathies, cortical brain malformations, or peripheral causes like motor neurons, of course, spinal muscle atrophy, the nerve, like the congenital hypomyelinating neuropathies, the neuromuscular junctions, example, congenital myasthenic syndromes, and the muscle, of course, we have the muscle dystrophies, metabolic myopathies, and congenital myopathies. When you think of central causes, think of the word strong. Strong, S denoting systemic signs. If the child has systemic signs, so this denotes that it is a central cause. T stands for tiredness or encephalopathy. If the child is encephalopathic, this indicates that he has a central cause. R stands for reflexes, which are brisk in central causes. O stands for occipitofrontal circumference size, whether the child has macrocephaly or microcephaly. This indicates that he has a central cause. Neurophysiological abnormalities, if it is normal, or epileptic seizures, indicating that we have a central cause. Also, the presence of genetic features and dysmorphism, indicating that the cause of this hypotonia is central and not peripheral. And when you think of peripheral causes, think of the word weak, because actually these children are weak. Weak, W, indicating that they have weak or absent reflexes. E, representing the expression that these children have myopathic facies, if, of course, congenital myopathy, and if spinal muscle atrophy, these children are alert and they can fix and follow. A, they are alert, and the K standing for maternal features, if the mother has any maternal symptoms, so we might think of peripheral causes of hypotonia. This table is just summarize what I have just said about the cerebral and peripheral causes. I'm not going to go through it. What about the history? Don't forget from the history to go systematically. Ask about the perinatal history, TORCH, maternal illness, if the mother has myasthenia or myotonic dystrophy, neonatal history, the mode of delivery, the NICU admission, the Apgar scoring, the developmental history, if the child has a delay or an regression of his milestones. What about functionally his feeding history, if the child has recurrent aspiration, choking, weak suckling, and of course the family history is very important. Look at the child, observe the dysmorphic features in Prader-Willi and Down, observe the eyes. If the eyes are alert and following objects, this indicates that it might be SMA. Ptosis and ophthalmoparesis, indicating that we have myasthenic syndromes. Look at the tongue. If the tongue is large, this might indicate Pompe disease. Fasciculations like spinal muscle atrophy. Look at the heart. If the child has cardiomegaly, it might point to Pompe disease. Liver or spleen enlargement, of course, in metabolic disorders, and skeletal abnormalities as arthrogryposis. The neonatal neuromuscular examination, of course, the pediatricians know it by heart, and adult, of course, neurologists know it by heart. The postnatal age, the motor examination, the tone, the posture, the mobility, the deep tendon reflexes, the primary neonatal reflexes, and of course, the functional status of the child regarding swallowing and respiratory problems. You You have, if you want to do a proper neurological examination, you have to have appropriate equipment. If you want to see if the child can fix and follow, use black and white circles, not because those children, they don't have colored vision. You have to have a tape to measure the head circumference. Of course, the hammer should be short because you are examining neonates, and you have to have a rattle in order to assess the hearing. The clinical evaluation, as we have just seen in the videos, the traction test, the shoulder suspension test, the ventral suspension, the scarf sign, all these might indicate hypotonia. This very tedious table indicate the different types between central and peripheral causes. I'm not going to go through them because it's very tedious, but I want to check if you were with me in the lecture or not, so I will have a small quiz with you. A 20-days-old male, he is hypotonic. His mother is 32-year-old mother, gravida 1, para 1, with normal vaginal delivery. His gestational age is 39 weeks gestation, and his birth weight is 3.5 kilos. Family history and consanguinity are negative, and I will tell you the clue. Look at the dysmorphism here. Who will tell me his diagnosis? Sorry? Prader-Willi syndrome. You are right. Prader-Willi syndrome. And this is a cause of cerebral cause of hypotonia. What about this child? Hypotonia and head lag. He has large tongue in the facial expression and cardiomegaly in his chest X-ray. What would it be? Pompe disease. Very good. This is, of course, a glycogen storage disease type 2, acid maltase, that those children have glycogen deposits in the anterior horn cell, liver, brain, and heart, with large tongue associated with cardiomegaly and sometimes hepatomegaly. A 2-year-old male, he has hypotonia and respiratory difficulties, ptosis, and he has a gastrostomy tube. And he has ptosis and ophthalmoplegia. What can he be? Yes, this might indicate that this child has congenital myasthenia, and of course we get impression on the clinical, from the clinical picture about the diagnosis, but we need further confirmations, of course. What about this child? He's a 1-month-old female, IVF with polyhydramnios. The mother is 28-year-old, gravida 1, para 1, 37 gestational age, 37 weeks, birth weight 2.5 kilos, ventilatory support since birth with neonatal pneumonia. His family history and consanguinity are negative, but the mother have hypothyroidism and cataract. What can this child be? The mother has symptoms. Congenital myotonic dystrophy or Steiner disease has to be considered in this child. This child is the product of a 23-year-old mother, gravida 2, para 1, intubated at birth with dysmorphic features, contractures, feeding problems, bilateral femur fractures, decreased intrauterine movements. Parents are first cousins with the previous pregnancy was terminated at the age of 23 weeks because of anomalies, and of course, see the severe hypotonia of the face. It might be, what would it hint? Congenital myopathies. Okay, this algorithm, I will end with it, my talk, about if you have a peripheral cause of hypotonia, and we just said the difference between the central and the peripheral causes. If you have a peripheral cause, if the CK is abnormal, think of congenital muscle dystrophy. If you have a congenital muscle dystrophy with central or eye signs, do MRI brain with fundus examination, ophthalmology, and genetics, because you can be in this category of diseases, the muscle eye brain disease, Fukuyama, or Walker-Verberg disorders. If you have a congenital muscle dystrophy but no central or eye signs, you can be in the category of congenital muscle dystrophies without eye signs or without central causes, the myrcene deficient or the congenital myrcene deficiency muscle dystrophies. If you have normal CK, and you have systemic signs like lactate or cardiac abnormalities, think metabolic, and you have to exclude Pompe disease in these children, because now Pompe disease has a treatment, an enzyme replacement treatment. But if the CK is normal and you don't have any systemic signs, no large tongue, no cardiomegaly, see if the weakness is more distal than proximal. Of course, think neuropathy and do nerve conduction velocity and next generation sequencing gene panel for neuropathies. If you have a proximal more than distal with eye movements that are good, no fatigue, think of congenital myopathy. If you have a proximal more than distal and ophthalmoplegia with ptosis and easy fatigability, think of congenital myasthenic syndromes. And if you have a maternal signs, if the mother is affected somehow, think of congenital myotonic dystrophy or myasthenia gravis, that is neonatal myasthenia gravis, that is transmitted antibodies from the mother to her child. As you can see, the SMA phenotype, as we have just heard from the videos and from the presentation, it has a very peculiar presentation with the tongue fasciculation and the severe hypotonia, and the alert child go for SMA gene, and of course, the CPK is normal, of course. And I will leave this inspiration quote that says, we always work for a better tomorrow, but when tomorrow comes, instead of enjoying, we again think of better tomorrow. Let's have a better today. Have a blessed today. Thank you very much.
Thank you so much, Professor Marianne Yosri, Cairo University, Pediatric Neurology. Everything I hear your lecture on clinical SMA, I learn more and more. Thank you so much. I think we will keep the questions to the end of the session because we are lacking of time. Let me introduce my colleague, Dr. Heba Hosni. Dr. Heba Hosni, I know her. She's a clinical genetist, and she taught us a lot about genetic testing. Today, she will talk about molecular diagnosis of spinal muscular atrophy. She is working now after taking her doctorate degree in the National Institute of Neuromotor System.
Thank you so much, Dr. Nagia, for these very nice introductions. And my colleagues and professors, it's my pleasure to be with you today and to discuss this very important topic, which is the molecular diagnosis of SMA, spinal muscle atrophy. It became a very important part of our work to confirm the diagnosis and apply the patients for the therapeutic and selecting the best option for them. So we'll start with a fine biography about the disease, the history of the disease starting in 1891 and extending to 1956 with the reporting of similar cases with severe hypotonia and floppy infants by the German professors Werding and Hoffman. And since 56, the approaches to find the genetic basis of the disease has been working very quickly by the discovery of the gene in 1995 and mapping it to the long arm of chromosome 5. And since the discovery of the gene in 1995, there is a great expansion in the field of genetic finding therapeutic drugs for this disease, and which is achieved in 2016 by the approval of the nusinersen by the FDA, followed by the approval of the gene therapy in 2019, and the last drug to approved in 2020, which is Evrysdi. So the disease is highly prevalent worldwide and having many cases worldwide, and so there's many countries have adopted different preventive genetic measures so to decrease the rate of the disease, because as Dr. Mariam mentioned in her literature, that it's causing high morbidity, especially in infantile and childhood period. So there are 3 measures of prevention, starting by the carrier screening and finding those who are carriers of the disease to select for them the best reproductive option, or the newborn screening, which is adopted also by many countries to introduce the SMA in its newborn screening, and so the selecting and early picking of the cases and very early treatment for optimal results. And finally, if we cannot achieve the carrier screening or the newborn screening, at least we can treat our patients and pick our patients through the molecular genetic testing very early, and so having also a better results from the therapeutic drugs. So the disease is autosomal recessive disorder, as most of us know, and in autosomal recessive disorders, we have 25% of both parents are obligate carriers, and we having 25% of getting an affected child, and having 25% of getting unaffected child, 50% of getting a carrier children's. But again, sometimes we are not, there is high incidence, of course, of consanguinity in the autosomal recessive disorders, but due to the high prevalence of the disease worldwide, we find many families who are non-consanguineous were having more than one sib who are affected. And this is according to the statistics done in the USA, that the carrier rate of SMA is 1 in 50 to 1 to 60 persons of apparently healthy population. You can imagine that 1 in 50 persons of sitting in this hall may be a carrier of the disease. So before we starting talking about the genetic molecular testing and the therapeutic agents available for the drug, we should refresh our minds with some basis of genetics. This is very quick. What is the gene? The gene, we know the definition. It is a part of the DNA that contributes to a known function. And the gene loci or location within the chromosome is known as the loci within a chromosome, and only about 1.5% of our total genome have a function. The rest of our genome, till now, we do not know a known function for it, till now. So if we do zoom in for a gene, we can find that the gene is consisting of nucleotides. These 4 basic nucleotides are adenine, thymine, cytosine, and guanine. And every 3 nucleotides forming a codon. And every codon call for specific amino acid. And in case the letters have been changed, the sequence of the letter has been changed, this may lead to different amino acid, and this may lead to mutation or not. And the old term is known as a mutation. Now it has been changed to a variant. And if we do zoom in more on this zoom in look and on the gene, we see that it is consisting of something known as exon and entrance. These exons are the actually coding part of the gene, and the entrance is non-coding part of the gene. When we do the protein synthesis process, it started by 3 steps: transcription, translation, and protein synthesis at the end. This is very important because we will say later that the therapeutic agents, which is nusinersen and Evrysdi, are working on the messenger RNA. But the gene therapy is working at the level of the gene. And this is very important to understand the mechanism of actions of the drugs. So the term mutation was an old mutation terminology used previously. Now, according to the American College of Medical Genetics and Genomics, they have changed this term to a variant. So this variant may be benign, may be pathogenic, or may be uncertain, or something we do not know whether till now it is benign or not. So we will give an example to simplify this. If the normal DNA sequence is known as theater, we changed the arrangement of the letters E and R to be RE. It have the same pronunciation. This is what is known as polymorphism. And the term polymorphism is very important also because we will mention that we use the polymorphism as indicators of certain findings in the SMA. And finally, the pathogenic variant, when we change the letter A to Z, it have a different pronunciation, and this is a pathogenic because it changed the pronunciation of the word totally. So what is the predominant mutation in SMA? This is very important. Why it is very important? Because we are going to select the test based on that. If the mutation is point mutation, we will select the test. If in our disease, if it is deletion mutation, we will select a different test. In our SMA, it is deletion mutation, which is related to a big category of this of mutation known as copy number variants. So if we are seeing this diagram, the simplified diagram, we can see these gray boxes, which is representing the exons. Between, we will find this entrance, the red line, which is the entrance. These gray boxes in SMA for 7 and 8 is deleted. And this is the predominant mutation in our cases, in 95% of our cases. So we have to check and to select the test that can detect this type of mutation. If we're selecting the sequencing method, it will not detect this type of mutation. So what is the best test for such mutation is MLPA qPCR. And if we are going to select sequencing, NGS technology, we should make sure that the copy number variant is coupled with the NGS data. There is another type of mutation, which is the duplication mutation, but this type of duplication we do not see here in the SMA. We see in diseases, other diseases like Duchenne, but the predominant mutation, again, in spinal muscle atrophy is the deletion mutation of exon 7 and exon 8. We mentioned that spinal muscle atrophy is autosomal recessive disorder. I am afraid it is not your typical autosomal recessive disease. Why? Because it has a gene modifier, and not only a gene modifier, it has also a variant modifier. So if I'm talking about the gene modifier in SMA, it is SMN2 gene. And if I am talking about the variant modifier, it is also a variant on the SMN2 gene, which is improve the clinical presentation if it is present in SMN type 1. Sometimes in your clinical practice, you find cases with type 1 have 2 copies of SMN2, and you find it is importantly, it's like type 2. And so you say, what is the correlation? Sometimes they have this variant on SMN2, and this is a gene modifier variant, which improves the clinical presentations in type 1. Also, there is a very sophisticated carrier scenario. We know that, as we mentioned, that autosomal recessive means that both parents are obligate carrier. And so when I confirm the diagnosis and we perform the test for both parents, we find that one parent only is a carrier and the other is normal. Sometimes this parent has the 2 copies of SMN1 on 1 chromosome. And so when I perform the test is normal. So I ask myself, is there something wrong? How this family have many offsprings with spinal muscle atrophy and one parent is normal? So I repeat the test again and I find that parent is normal. So they discovered this scenario that both copies of SMN1 in certain ethnities like the Ashkenazi Jews and the Asians having the 2 copies of SMN1 on 1 chromosome, and they find a specific polymorphism and specific variants of SMN1. If it is present, this indicating that these 2 copies are present on 1 chromosome, and I should understand this because these carriers are missed from the genetic testing. So we talk about 2 genes, very important genes in our genetic diagnosis. Don't forget, and this is a home message, one of the home message, that SMN1 is your diagnostic gene, SMN2 is your prognostic gene. And so the difference between them, 99%, they are identical, except in one nucleotide in the exon 7, which is the 850, where the C is replaced by the T in SMN2. Also, both genes are located on the long arm of chromosome 5. The one which is near to the center is SMN2, and the one which is near to the end of the chromosome is SMN1. The protein is very important for the whole mammalian kingdom, and not only in human beings. It's very important in rodents, in insects, and in human beings, and the complexity of the protein is formed measured by SMN1. So, one of the very also important slides today, this is the result in interpretation. If we had a result for the spinal muscle atrophy disease patient coming to our clinics, and he had the report, what is the possible scenarios that we will have in this result? The normal population having 2 copies of SMN1 and having at any number of copies of SMN2. But for the affected, they have 0 copies of SMN1 and at least 1 or 2 copies of SMN2 because it is incompatible with life. He cannot live. The protein is very essential. For the carriers, the most common scenario that I have only 1 copy of SMN1 and any number of copies for SMN2. So this is the most common scenarios in our results, in our reports. But what is the uncommon scenarios? For the affected, we are having point mutation, deletion on one allele, and point mutation on the other allele. And so when we find a clinical case having the same features of SMA, and I perform the test, and I find the deletion, and he is a carrier, and I can say that the carrier is healthy. How is affected? I do not forget that some cases had a point mutation on the other gene. For the carriers, he may have a point mutation only, not deletion, and this is a rare scenario. And for also the carriers, as we mentioned, some carriers has the 2 copies of SMN1 on 1 chromosome, and when I perform the test, I find him normal. He is not a carrier, although he has many offsprings affected. Again, we do not forget that not SMN2 is only a modifier for the disease. He has a variant, which is a modifier also in type 1. If I find a case of type 1 and its clinical presentation is less severe than expected, do not forget that some cases have this modifier variant on the SMN2, which decrease the severity of type 1. Decrease the severity of type 1 and make it look like type 2.
موضوع شائك جدا يا دكتورة هبة. الحقيقة الجيناتكس دي الواحد بيتوه فيها، بس انت حقيقة
حاسة ان الموضوع very complicated.
بطريقة جميلة جدا.
ان شاء الله نخلص بسرعة. So accordingly, SMN1 is your diagnostic gene, SMN2 is your prognostic gene. So type 1 has 2 copies, type 2 has 3 copies, type 3 has more than 3 copies. Genetic testing in general is divided into 3 main categories, which is cytogenetic, molecular, and biochemical. What is important for us is the molecular, and in our disease, it is deletion, duplication, analysis, which is the test we are targeting, and so it's very important to ask ourselves, what is the predominant mutation in our disease to select the best test? So we have the MLPA, which is the gold standard method, or the qPCR, or to couple the NGS sequencing if we select the sequencing with the copy number variant analysis. The gold standard method, again, in our disease is multiple ligation probe amplification. Previously, we select the polymerase chain reaction and the PCR because it is cheaper. We were utilizing the quantitative, the real-time PCR, and now the new adoption of the PCR with the RNase H-dependent PCR with less fallacies and better selections and less false negative results, but still the gold standard method is multiple ligation probe amplification. The clinical presentation is being discussed previously by Dr. Marianne. I need just to highlight that the treatments available, the 3 drugs available, and the 2 drugs with the gene therapy is working differently. One is working on the gene. Therapy is working in the gene itself by adeno-associated virus vector carrying a copy of the gene. The other 2 drugs, as we mentioned, is working on the messenger RNA, not working on the gene. It's the Everesdi and the nusinersen are working on the SMN2 messenger RNA to increase the amount of SMN2. As we're saying, it is the prognostic gene. So as we much increase the disease, the severity of the disease will be decreased. The classification of the disease previously was depending on the type, the number of copies. Now it is depending upon the age of the treatment. We can see that type 1 is turning to type 2 or type 3 if the treatment is taken as early as possible. And this is the taking home message. It's autosomal recessive disorder. Genetic counseling is giving that both parents are obligate carriers in 98% of the cases. Only in 2% only that a de novo mutation can occur on one allele, and these offsprings or the other septs will not be at a high risk, but in the majority of the cases, autosomal recessive, obligate carriers, and other relatives, other offspring should be offered the genetic testing. The family should be offered prenatal testing for the next pregnancy. Thank you. And I'm so sorry that I'm prolonging the time, Dr. Nagia. But as you see, it is very complicated.
أشكرك شكرا جزيلا دكتورة هبة. الحقيقة دكتورة هبة had got her PhD in genetics, and هي الحقيقة مرجع لينا في اللجنة العليا في القصص بتاعة التيستس لما بتيجي الانتربريتيشن بتاعها. أشكرك شكرا جزيلا دكتورة هبة. ودلوقتي يعني يسعدني ويشرفني إن أقدم صاحبة هذا العرس، ويعني الأستاذة اللي دايما لما ببص لها ما بعرفش، يعني بقول لنفسي ما فيش يأس، ما فيش يأس مع الحياة. هي she is always enthusiastic, she is always the dynamo of اللجنة، وهي she is trying to help as much patients as she can. دكتورة ناجية بشكرك على الاحتفال ده كله.
ألف شكر ليك يا فندم.
وهي دكتورة ناجية طبعا النهارده هتتكلم على أهم حاجة بقى في الاس ام اي، the emerging therapies of spinal muscle atrophy. كلنا أذان صغيرة. دكتورة ناجية اتفضلي.
ألف شكر. بسم الله الرحمن الرحيم. طبعا دكتوره هبه حسني بسطت لي الامور، اقدر انا اخش واتكلم على الثيرابي. اكيد طبعا الجيناتكس مش سهله، بس احنا ككلينيشنز بنحاول ان احنا نفهم كل مرض والجيناتكس بتاعته. فاحنا هنتكلم على الايمرجينج ثيرابيز اوف اس ام اي، وطبعا خلاص احنا كلنا عارفين ده نتيجه المرض ده نتيجه الجين اسمه SMN1 جين، وان هو second most common fatal autosomal recessive disorder after cystic fibrosis، وبيحصل من 1/6000 ل 10,000 live births. We know that the main pathology is the anterior horn cell. It is the main pathology. This is a healthy one, healthy nerve and healthy muscle. When there is a mutation, there will be a degeneration and death of the anterior horn cell with the supplying nerve and atrophy of the muscle, and hence it is a purely motor trunk and the proximal limb weakness. And we know there is regional differences in the estimated prevalence of SMA, already described by Professor Marianne and Dr. Heba, that it's a autosomal recessive inheritance. There is a carrier mother and father, and then every child has a 25% to be a disease, 25% to be unaffected, and 50% affected carriers. But we found that although worldwide it is prevalence is 1 to 2 per 100,000 persons. In Egypt, we found in a work done in Ain Shams University to be estimated to be 17.7 to 100 persons. And this high frequency of SMA in Egypt is due to the high degree of consanguineous marriages, at least 45.5% for patients with type SMA SMA type 1. So the classification already described by Professor Marianne is the type 0 that die very early, type 1, 2, 3, and 4. And the severity will be attributed to the number of SMN2 copies, the guarding gene. If you have more copies, so the disease is less severe. If it has less copies, so it is a severe disease. But I want to mention that we are talking today about the proximal SMA, the SMN1 gene mutation. But there are atypical SMA, the distal SMA, the bulbospinal, the SMA with CNS involvement, and other types. These are non-5q SMA. It is not that related to chromosome 5 and the SMN1 gene. There are other gene mutations. The new therapies will help this mutation only. So now we know that we have SMN1, the gene that is the normal one, and this, if mutated, will cause a disease. And this is the backup SMN2 gene that its presence in a number of copies will produce some proteins that help to modify the clinical diagnosis. What happens in the disease that we have mutation of SMN1. So the clinical condition will depend on how much we have of SMN2, how many copies we have of SMN2. And this is a basis of treatment. Either to replace the SMN1 to work as a DNA level, to transfer DNA similar to SMN1, this is gene transfer, or to modify SMN2. We said that this T nucleotide is a cause of that we have a small amount untruncated protein. If we do something here to skip this one, or to include this exon 7 in the messenger RNA, so maybe we will have more protein. So this is a basis of gene modifier. So either we did gene transfer working on DNA level, or gene modifier working on a messenger RNA level. And we know that, of course, these patients, especially type 1, at the end of 20 months, only 8% survival. So, what more important before we said, we talk about the gene therapy is a multidisciplinary approach. We recognize through the last year during therapy that without this multidisciplinary approach, even after we give the children the gene therapy, if we don't have a pulmonary assessment, a nutritional assessment, and support, if we didn't have a good physiotherapy, these main three treatment multidisciplinary team, our patients will not survive. So today afternoon, we have 2 sessions on 8 subspecialties of the multidisciplinary team. And many publications about the multidisciplinary team. In the past, the family has to go and run to search for consultants. Now, we recommend that the lead physician, the pediatric neurologist, the neurologist, and neuromuscular consultant will coordinate for the family and patient, all the consultants of the multidisciplinary team. And now we have a novel SMA gene therapy. This disease is very lucky. The first one to have 3 genetic therapy. One is gene transfer, the Zolgensma or unasminogene, and 2 are gene modifiers, the nusinersen spinraza or the risdiplam. All the 3 are FDA approved, EMA approved, and approved in many countries. The Spinraza is the first appears in the end of 2016. This is an intrathecal therapy, and it depends on antisense oligonucleotides. It is given for all types 1 to 4. The gene therapy is single intravenous injection, a gene transfer. It is given to type 1 and 2 until 1 FDA approved. And the last one, the risdiplam or Evrysdi, is oral therapy. It's small molecule, again, to modify SMN2 gene, and it is given for the 4 types. Here is the mechanism. As I already mentioned, they will work on SMN2 to modify the gene, either risdiplam by a small molecules for splicing correction of exon 7, or nusinersen as an antisense oligonucleotides also work on exon 7. So both will modify the messenger RNA to include exon 7 in it, and to have not full length, but a better SMN protein, a better amount, a better functioning, so we can give the disease. While the gene therapy, it will work on SMN1 gene. It is SMN1 directed therapy. They formulated or manufactured a DNA similar to SMN1, carried on AAV9 gene, and this DNA will give a full-length messenger RNA and give us a full-length and functional SMN protein. So it is directed to address the genetic root cause of SMA. The first one is nusinersen or Spinraza. Fortunately, we started the first 14 patients in Egypt last month, and it is already started to be given by the insurance, but not routinely. And the recommended dosage, it is 12 milligram vial. We give a loading dose, then a maintenance dose. Loading dose day for first day, after 14 days, then after 14 days, then after 30 days, then a loading, then a maintenance dose. يعني first 2 months we give 4 doses, then every 4 months intrathecal injection. And also we have a real world for this treatment. About 11,000 patients through clinical trials or through real world, they took already Spinraza. Next 2 days, we will have 3 symposia about the gene therapies, and all the clinical trials will be explained. In every drug of them, the pre-symptomatic, first in Spinraza, the nurture study, and other drugs I will explain. The pre-symptomatic studies are very important because they give us results almost 95 to 100%. At 1 year, he will be, looks like a normal child. So it is better to give before the symptoms appear. And the second drug is the risdiplam. This is it is registered now in Egypt, and we have the drugs. Also, Spinraza is filling the papers of registration, so you can buy from the pharmacy any drug now. It is only the cost. This is an oral one. And again, we said that it works on SMN2 splicing modifier, and it will modify to increase the amount of messenger RNA and to have a functional SMN protein. Of course, many clinical trials are done, and it is finally FDA approved in August 2020, and it is also approved in Egypt, EDA approved in June 2021. Also, as I already said, it is a gene modifier, SMN2. Many trials, risdiplam trials, type 1 and type 2, but the rainbow fish, the pre-symptomatic clinical trial is very important, and a parallel results like that of nurture or Spinraza to give before the symptoms appear, and death of anterior horn cell is better than to give a patient with symptomatic disease. And of course, the last drug is onasminogene, Zolgensma, the gene therapy. As I already mentioned, it will be calculated according to body weight. It is once in life. It is once in life. And we took the gene therapy intravenous through a virus vector. Then it will enter inside the cell to be surrounded by endosome. Then it will get out of the endosome, and only the DNA of the gene will enter in the nucleus. It will not, and this is very important, it will not integrate with the human genome. It will form a separate episome and continuously given the protein. Of course, many trials, but what is important is the rapid and durable motor function improvement. And CHOP intent, one of the functional tests we use, showed steadily increase. I want to mention that by using the 3 drugs, each patient will have his drug. Each patient, we can choose which drug for him according to type, according to clinical condition, according to number of copies, according to other systemic affection. But every day, the child will gain function and not lose function. Every day you give the intrathecal, or you give the oral, or you give already the gene therapy. Every day he will gain function and not losing function, and this is what is most important. But after 1 year experience in this, the committee had an experience now what we have to do and what protocols we have to do. We need that to change our mind that all newborns must have clinical assessment, or even we must have a newborn screening to discover these patients very early. Even we thought about the carrier detection to decrease the number of patients needed for this expensive therapy. We have to ensure referral of suspected SMA cases to SMA specialized clinics. Now we have specialized clinics following the insurance. There is a molecular diagnosis free of charge and in accredited laboratories. And also, we started to conduct the post-treatment follow-up and the collaboration with a multidisciplinary team. We are trying to doing this now in every center because this is the most important. And my last take-home message is the earlier SMA is diagnosed, the earlier the patient will receive the treatment, and of course, this will result in better patient outcomes. Thank you.
I would like to express my deep thanks to Professor Nagia Fahmy for her eminent presentation, which explore and clarify, update the novel drug and gene therapy in the spinal muscular atrophy. And my deep thanks to Professor Marianne Yosri and Professor Heba Hosni. And now we can open the question in related to the session.
I would like to thank all the speakers for this very fruitful session. Professor Marianne and Professor Heba, Professor Nagia. My question is for Professor Nagia. Regarding the age, I've heard now that it's better to be given before 6 months of age. But before, we used to tell the patient that before 2 years.
You are talking about the gene therapy.
The gene therapy,
because
yes.
it is the first one approved to be given in Egypt.
Yes.
Yes, it is FDA approved to give the gene therapy to type 1 and 2 before 2 years of age. But after we gave the first year, we found that many patients, especially type 1, they didn't give us the good response that we need. And you know that this is a very expensive drug,
Yes,
the most
yes.
expensive in the world. So, especially for type 1, we thought if we give very early, before 6 months, and we prefer that first or second month, just appearing of the symptoms, this will give us the most benefit from the disease.
Yes.
But we will miss type 2 that will appear after 6 months, and
Age.
this is the debate now. We are trying to check our results for the last year. We found those patients take very, very early are good, but those of type 2 who took also the therapy are good, giving good results. So we will start to ask to change the protocol again, but we cannot promise. We need approvals. The second thing, we found that to start pre-symptomatic This is the ideal. Before any symptoms, before death of anterior horn cells, and
Yes.
you will not need to pay for all of this care, and this will be the most benefit for the patients.
You remember Salma Omar? I referred this patient at 3 months. She was lucky, but unfortunately, after the processing of papers, although it was very fast actually, it wasn't delayed, but unfortunately she died at maybe 3 months and
This is a
15
problem.
days or
This
something
is a
like that.
problem.
So
if we give
early diagnosis
if you give type
crucial.
1 after appearing with the symptoms, maybe the child will die, the infant will die,
Yes.
and we will lose the therapy. So that's why we started to check our results, and again, I think the protocol will be changed again.
In your opinion, you remember Rukaya?
Yes, of course.
Rukaya, yeah. I actually shared in one program in BBC News for the fundraising for her, and actually after the program, they gathered like 15 million, alhamdulillah.
Rukaya is very lucky.
Yes,
She
yes.
started to stand and walk.
Yes, this is what I
And
want to know.
I am following her in
Yes,
Alexandria.
yes.
She's very lucky, and thanks for all of you.
And thank you very much.
Rukaya is type 2.
Yes, Rukaya is type 2, but
That's
she
why
had
the
few
committee-
days.
That's
She
why
had-
the committee is thinking again, because type 2, as already Dr. Marianne said,
This
it
is-
starts after 6 months.
Yes,
So
yes.
we are thinking now about type 2, but starting also very early.
I remember that she had only 1 week remaining to be 2 years. So alhamdulillah, alhamdulillah, they gathered everything طبعا مع وزارة التضامن before 2 years exactly, and she had, as you said, good results. So I hope the committee will change
Yes,
this for
yes,
type 2.
yes.
Thank you very much. Thank you very much.
I think we are out of time, so thank you so much. We have a coffee break. 30 minutes is enough, so we can come back. Thank you.